Haley, would you press the go button, record? Thank you. And the recording will be available on the website. So welcome to the meeting of the Mental Health San Francisco Implementation Working Group. We,
The recording hasn't started yet. You need to wait for the recording to start?
yes, I do.
Okay. Haley, can you tell us when the recording has started?
It says it's already been recording for 28 seconds.
Okay, go for it.
28 minutes. Before we start, Chair Lassar is sick today, so she's not going to be able to make it. I am wondering if someone would be so kind as to, and Vice Chair Patterson, oh, he's not Vice Chair anymore. We're still waiting for Vice Chair. So hoping somebody can chair this meeting. If somebody would be welcome to do that, and I'm happy to support however it is. It's kind of moving along to different agenda items. Any takers? Script.
We're all staring at each other.
Right now.
Do it, or do you want me to?
I want you to do it.
Everybody's
Yeah.
looking at me, okay.
Here's your.
And I can read. So Hallie, I could do anything in it that you would like.
Okay.
Is it time for you to do a motion for a vice chair? Well, we've gone 3 meetings avoiding the.
So would you call the meeting to order?
Okay, I'd like to call this meeting of the Mental Health San Francisco Implementation Working Group to order. Thank you all for being here. I know it's a schlep and a little hard to park around here for those of you who drive. So thanks everybody for being here. So we're gonna start with roll call. So who's gonna?
I could do roll call.
Can you advance the slide, please, Kaylee? Thank you.
So roll call will now be taken to establish quorum. Upon your name being called, please respond with here or present. And if somebody's absent, I will say not present. So member Eisen.
Here.
Member Fields.
Here.
There.
We see him.
Can you unmute, Steve? No, because that's just an AI, you know.
Hold on 1 sec.
Oh, wait, we got, okay,
Here.
thank you. Member Gonzalez.
Here.
Member Hammer.
Here.
Chair Lassar is not present. Member Lipton.
Here.
Member McGuigan is out. Vice Chair Patterson is out, not present. Member Salinas.
Here.
Member Short.
Here.
Member Wong.
Here.
1, 2, 3, 4, 5, 6, 7, 8. So we have 8 out of the 13 present, so we have a quorum to continue, which is at least 7. And we did already verify that the sound is working. So Kaylee, can you hear when other people talk?
Yeah, a couple minutes ago, like when you guys were laughing and clapping, like it went out, but so far everything's been crystal clear.
Okay, so that is our colleague Kaylee, and if you are speaking and she can't hear you, she's taking notes, so she will scream and shout and ask you to speak up.
Thanks, Kaylee.
So we have confirmation that the public access is working, so we are good to go. Oh, so do we have to excuse?
Slide, please.
Oh, next slide, please, Kaylee. Okay. So per IWG bylaws, the IWG must vote to excuse an absent member from a working group meeting. If the working group does not take such a vote at the meeting or at a previous meeting, then the minutes shall note that the absence is unexcused. Any member who misses 3 regular meetings of the working group within a 12-month period without the express approval of the working group at or before each missed meeting will be deemed to have resigned from the working group 10 days after the 3rd unapproved absence. So members McGuigan, Gonzalez, and Fields. Nope,
Now
this
it's
is old.
changed. Now,
Okay.
now it's changed. So now it's
Members,
McGuigan, Patterson, Lassar have all
submitted
written to submit
requests.
requests to be
Okay.
excused.
Okay. So is there any discussion on those before we vote? Okay. So I will now take a roll call and ask each member to vote yes or no to excuse members.
McGuigan, Chair Patterson, no, Member Patterson and Chair Lasar.
Okay, member Eisen. Yes. Member Fields.
Yes.
Whoa.
Whoa.
Member Gonzalez.
Authoritative.
Here. Do you?
Yes.
Sorry. Member Hammer.
Yes.
Member Lipton.
I can't manage the baritone, but yes.
Member Salinas.
Yes.
Member Short.
Yes.
Member Wong. Okay, we have 8 yeses and 0 nos. We have a majority to vote to excuse the absences.
Great. And then next we have our meeting goals.
Next slide, please. There you go.
Right, these are the goals of today's Mental Health San Francisco Implementation Working Group meeting. We're going to get an update from Hillary, who will be joining us over Zoom from Director Clemens. She'll give her update on behavioral health services and Mental Health San Francisco. And then we are going to review if the working group chooses to, on recommendations related to IWG, specifically the crisis response team. So we got the email from Valerie yesterday evening. That's still the plan?
Yes.
Bullet two? Okay.
Yeah, so when we get there, we'll kind of
talk about
go through it, yeah.
We're gonna have an update from new beds and facilities. We are going to talk about how we're gonna organize ourselves now that we're in person. And then we're gonna have a discussion on DPH and IWG interests of topics for the next meeting. So that'll be an open discussion, okay? So this is the domain sort of foundational organization of Mental Health San Francisco that you all are familiar with. Just shows who's addressing us today. Director Dr. Hillary Cunnins and new beds and facilities lead Dr. David Payton. Okay.
So can I have a question about the domain? Do we still consider the street crisis response teams to be a domain?
Speak to what's it is. So I spoke yesterday with city attorney about a number of things.
Okay.
I asked that question of them repeatedly. They've sort of declined to give me a definitive answer. They say it's still in the ordinance. We've talked about various methods of continuing to update on it. They do recommend that we will continue to talk about what we are doing on our side. So the team that is now under the Office of Coordinated Care. We will continue to provide updates on our coordination with SCRT. And I think they do not feel that the reconfiguration of SCRT has removed it from MHSF. They, however, decline to sort of give me any more guidance than.
Okay, I'm sure we're going to discuss this later. I just wanted to just ask as
Yeah.
just a general question,
Yeah, so.
of whether it's still considered to
You
be.
just wanted to
domain.
open a can of worms.
Yeah.
I think worms is
So-
too nice a term, but okay.
I mean, I think also that because Dr. Cunnins is Director of Mental Health
Yep.
San Francisco, it'll be helpful for us to hear her
Yeah, no,
take on that. So what
absolutely.
her relationship is
Yeah.
to SCRT and BHS is.
I was just looking for a very baseline answer. I wasn't looking to get into a discussion about it. Okay.
Okay, so we're gonna go into any other questions on the previous slide of the organizational structure? Steve, I think it's a great question and hopefully it gets a little clarity.
Well, no one's ever attacked this slide before.
So approval of the meeting minutes. Any discussion first on the meeting minutes? Oh, wait, sorry. First, it's public comment. First is public comment. So,
Well, first we need to have discussion here and then we'll go to public comment.
okay.
Sorry. Yeah, are there any changes that this group has to?
Okay, sorry.
Yeah.
You getting it? A meeting like this would. Okay. All right, any changes to the minutes as posted and sent out to us? Okay, and then, and I want to say, I thought the minutes were really well done last time, so. Yeah.
That's Haley.
Thanks, Haley. Okay, let's open it up to public comment.
Okay, so members of the public who wish to provide public comment on this agenda item, which is approval of the meeting minutes from March, are invited to participate in 3 ways. The first one is the people who are here in person. And is there some specific, they could probably just comment from where they are. Okay, so that's the first way. So they're going to get to go first if they would like to, and then I will call on participants who have raised their hand on video. If you are participating by video, raise your hand and somebody will call on and unmute you when it's your turn. Then we will call on those joining by phone. If you are joining by phone, please follow these instructions. If you would like to make public comment, call 415-655-0001. Enter access code 24825961324. Press pound, then pound again. Then dial *3 to line up to speak. A system prompt will indicate that you have raised your hand. Please wait until the system indicates that you have been unmuted, and then you will begin your comments. Please note that you will have 3 minutes. I will give you a 30-minute warning, a 30-second warning. It says minute, 30-second warning when your time is nearing completion. So would anybody who is in person like to comment on the March meeting minutes? Okay, nobody in person would like to. Anybody on video? Kaylee, do you see anybody raising their hand?
No, not yet.
Okay, and anybody, do you see anybody requesting to be unmuted by the phone? I don't think anybody has joined by phone, just by phone.
I don't think so.
Okay. So hearing no further people who are anybody who'd like to publicly comment, public comment is now closed. Okay.
And Diana, you're gonna.
So now I get to go again. You get to hear me a lot now. So we will now vote to approve the March 2023 meeting minutes. Do I have a motion to approve the minutes? So member Eisen moved. Is there a second? Okay. I will now call roll and ask each member to vote yes or no to approve the March meeting minutes. So member Eisen.
Yes.
Member Fields.
Yes.
Member Gonzalez.
Yeah.
Member Hammer.
Yes.
Member Lipton.
Yes.
Member Salinas.
Yes.
Member Short.
Yes.
Member Wong. We have 8 yeses and 0 nos. We have a majority vote to approve the March meeting minutes. Back to you, Chair.
Okay, so we're now moving on to discussion item number 2, our update from MHS and Mental Health San Francisco Director Hillary Cummins.
Family medical thing she's dealing with and is interacting with a nurse right now. She'll look at it as soon as she's ready and wondering what we might be able to cover. Where this might be a message.
Okay, let's see. It seems like new beds and facilities may be something that stands alone, a little separate from the other discussions about skirt and resolutions and that are tied into Hillary's presentation. If Dr. Pading is on the phone, or could we?
I just messaged him to see. Try to go by his office. If he said,
I thought I saw him in the hall.
oh, yeah.
To rat him out, but
Or perhaps organizing ourselves now personally.
we can do that.
Yeah.
Okay, let's do that.
Okay, and just in case Dr. Cummins takes longer, can you ask Dr. Pading if he could step in and, thanks, Valerie.
Kaylee, if you could advance to, it's after the break.
It's slide 22. It should be around there.
Okay.
It's called
Okay,
This is discussion item number 5.
okay. So give me a sec.
Keep going. To be right after this whole section.
Okay.
Going there.
All right, so with our now meeting in person, we thought it would be a good idea to have a discussion of how these meetings are going, how we might improve the format. The challenges that we've heard, next slide, are that the meetings are very long and packed, that we don't have enough time to discuss. The meeting structure does not promote conversation between members, and those often have to happen in these structured working groups that happen inside these meetings, that we don't have enough time in advance for prep and the technology challenges. So before we discuss, are there any other challenges that people want to mention?
Yeah, I'm not sure what the succinct way to say this is, but input of members on developing the agenda.
Great.
Oh, hi.
David. Hi, David. We actually.
All right, I'm actually thinking that I think this is, we're gonna have a whole discussion on this. I think this is why we were gonna have like a whole retreat. So is it okay with everybody if we just table this? Thanks for your addition, Sarah, and go to David and then come back to Hillary and this. Sorry to jump around so much.
Be the poor person writing the minutes.
Yeah. So Kaylee, we're gonna.
I'm putting the acting chair.
I know, it's all my fault. I'm taking full.
Very, very nimble.
Yeah.
Okay, so we're gonna go back to new beds and facilities, which is slide something after the skirt. 17. And David, thanks so much for hopping on. We welcome you back to the Mental Health San Francisco Implementation Working Group. Thanks for being with us, and we're looking forward to your update today. I'm just gonna give a little spiel just to bring people to this topic. Expanding existing models is sort of the this within the scope of the Mental Health San Francisco New Beds and Facilities Domain Group. And we've given input on program expansions and program development in the past.
Haley, can you advance the slide?
DPH brings updates on the expansion in residential programs to us, and also gives us updates on how this work is evolving over time. The work group provided rapid response recommendations on a new residential treatment project in May of 2022, and DPH subsequently came back to report on the project in October of last year. So, and then for anybody who wants to sort of review our discussions in the past and the updates, all of those materials are on our IWG website. We also provided some initial recommendations on drug sobering, the crisis and transitional age youth, new residential programming, and we can find those as well. So David's going to update us on how New Beds and Facilities is going. I think has some exciting news about new beds opening. So David, I'll hand it over to you.
Yeah. Just ran to the restroom or something.
Oh, okay, what can we talk about in the?
Please get ahead. They're gonna be.
In the meantime, did everybody sign the?
Yeah,
Okay.
folks could sign the sign-in sheet. It's necessary for this to be. done.
We all signed in.
They did.
We both did.
Yeah.
Anybody?
I just also want to make sure that especially new members, so that people are familiar with the dashboard that you see in the upper left. I don't know that David's going to talk about that, but that's updated, I think, monthly. And really has some good detail about the beds we've added, some new programming. If you're wondering like, what is that thing that proxy support is going into that needs to open? I think there's good information there as well as, and you can also track how we're doing getting to the over 400 beds set out to open at the beginning of Mental Health San Francisco implementation.
So is this like real-time updated or is it more like?
I know it's monthly. It's
Okay.
monthly. Yeah, it comes out monthly on a regular day.
Okay.
And if you go to that, hey, David, you're in person. And if you go to the link, that's there, it says exactly the methodology.
Okay. Thank you.
Welcome, David.
David.
Thank you for being flexible and coming to join us.
You could move this, we'd like to see here. We're not using this.
So your slides are updated.
And you can just say next slide.
Touch it?
No, you just say it.
Well, you can touch it.
And members, I've invited the public to sit nearer the table so they can see the slides. Okay.
Is there a camera somewhere?
That's
It's, I think it's right.
You're in it.
Under the key.
Down,
Oh, so which way do you want me to face? Do the mouse?
Face this way.
Yes.
Well, it's good to see you all here. Went to City Hall, realized that you weren't
Oh,
there,
no.
came back. Yeah, that's great. So welcome to our humble home. I'm going to give you an update on new beds and facilities. We have not talked to you, or haven't talked about new beds since October. And then we were going to come back in January and then February, and then you guys have meetings, and so we're off again to April. So this is just a status report only. We've had one new big breakthrough, which is opening 70 beds residential step down on Treasure Island. But just take any questions that come on up. Now with time, do you want me to rush through or have we?
Just you to be you.
Okay.
Yeah.
So I just want to orient you that, again, mental health, the new beds and facilities is one of the 4 parts of the Mental Health San Francisco, and that we were mandated by the act to develop a crisis residential service, a secure inpatient or individuals, beds for who are conserved. A lot of this is locked facilities. Transitional residential beds, which would be residential step down or various forms of mental health transitional beds, and long-term supportive housing, which also includes board and care. So those are in the mandate. You'll see, next slide, please. On the dashboard, of course, we also then looked internally within our own dashboards like Fine Treatment SF and our utilization studies, and came up with a need for 400 plus beds. So the ones in green, they're going from Hummingbird, Valencia, managed alcohol program. These are the beds that were specifically outlined in the bed study by Dr. Anton Negussi-Bland and the Health San Francisco. LSAT beds, PSNF, not dual diagnosis, residential care, board and care beds. And then to that, there was a summarize, which was required by the act, and a crisis diversion facility. And then we added other programs that were needed based on our internal studies, again, Fine Treatment SF. I think it's been, pretty intuitive. We've had this now up for a long time. And I think the important point is that we're 350 beds on the way to 400. And what you see here is left over, it's 30, 40, 56. So we're quite pleased that we've made a lot of progress in 2 years. Next slide, please.
Can I ask you?
Yeah, stop anytime.
Okay. I have to ask, what is the status of those Hummingbird beds with PRC Baker, issues, and are they still being run by them, or are they being taken on by someone else, or just what, are they stable?
So Young Jung Kim is our expert on Hummingbird. She's managing the contract.
Okay.
my understanding is Baker is still managing it and will continue to manage it.
Okay.
It was initially on a pilot, and then that pilot has been extended, and there's like an evaluation going on of Hummingbird as the pilot. So we're discussing, should it move to more of a contract status or an RFP status? These are things that our business office, and they're very complicated, can move this one because of that. And
There's still the two.
there'll be a
locations?
continuation of, there's no discontinuation of service.
Yeah, okay. Still the two locations?
Yes, there's Potrero and Valencia.
Valencia, yeah.
Yes.
It says, oh, I see, serving people from Mission and Castro.
Yeah,
Okay.
so the Valencia with Mission and
Got
Castro,
it. We're looking at,
right,
Same
this is
one, yeah.
Valencia, and then Potrero is its own site.
It predates mental health.
yeah, I remember, yeah, yeah. Okay, thank you.
And Potrero, I understand there might be some construction or something going on at that facility. I don't know all the details of that. Okay, but these are open, will stay open, as far as I know. Next slide, please. Feel free to stop at any time. So the first project I want to give you update on, when I just spoke with you, it was opening. We opened the Minna project. This is located at 509 Minna, which was a tourist hotel turned into a 70-bed transitional residential program. So we call it transitional residential because it's not a licensed residential program. It's transitional in the form of like transitional housing that allows people to stay 1 to 2 years. And we did this as a program jointly with adult probation. And we hired 2 subcontractors through adult probation. They contracted with Westside Community Services, and we extended on our side citywide, UCSF citywide case management, which did a lot of services. Andrea would know this, into our SRO hotels. And given that this was sort of a residential model, citywide was a good extension. Plus citywide staffs the CAS Center, which is the adult probation's outpatient service center. So a lot of the clients were similar or were using similar services. So it was a nice match. Next slide, please. I want to give you the status of where we are with the Minna project. We're now into, is that 9 months? I think like 9 months. And we've been running steadily about 65, 68 clients in 72 rooms. Of the 75 rooms, 3 of the rooms have been converted or are used as transition rooms as people are moving in and out to their various levels. They'll come in, they'll wait. It's sort of it's like 3 or 4 person bed to a room, but all the other rooms are singles. And there's been a lot of progress in this. So 17 clients have stayed more than, let me go here first. Let's give a graphics. Most are men, but we do have women there, and there's one transgender client, female transgender client. We're serving the population that we need to serve, in that 28 are African American, 23 are Caucasian, 20 are Latinx, and as you know, these are priority populations for the department. 2 are Asian Pacific Islanders, and I'm not sure what the one other is. This is preliminary program data. I just asked them, they went through their spreadsheets, they're counting. One of the things about this program is there's no Epic, there's no avatar, everything's done by hand, although we're moving to Excel with the data. 17 clients have been more than 8 months, so that there is a group of people that are staying and finding this program helpful. They can stay up to 1 to 2 years. I'm going to go down to the punchline here, and 35 have already moved into permanent supportive housing. So we're very proud of this number, since housing, employment, education is really the goal of these transitional programs. 9 are monolingual Spanish speakers. We've been asked by our state reviewers, the EQRO, to develop Spanish-speaking programs, particularly for those coming out of jail. We have a lot of men, cocaine, alcohol, Latinx, and Spanish speakers. So it's been easier to build Spanish capacity in our newer programs. And so we have 9 monolingual clients, and we have a very competent 24-hour Spanish-speaking staff. The program manager, Spanish-speaking, numerous staff, and we're looking for a social worker. If you know a Spanish-speaking social worker, they're ready to hire. We have 35 clients diagnosed with serious mental illness at this point. And 30 of the clients are enrolled in the city-wide mental health case management. The reason it's 35 and not 65, even though it's a dual diagnosis transitional program, is we're only still getting citywide up to speed. It's taken a long time. They're getting their nurse on board for medication management. And so in the beginning, we said start slow, go low, and now they're gradually building their acuity and capacity as the program gets settled. 13 are medication management, and actually, I think there's more than that. So, and then 72 clients have completed 90% of their SMART goals. This is particularly important to our ADP adult probation clients. They really want to help people work towards their progress, and they work with a SMART plan within the program, and are very proud of the support they're offering. And I think the result is here that we're seeing people getting placed and moving on. Any questions about Minna at all?
Do you have any information about where they've obtained permanent housing?
No, I don't.
Okay.
Yeah, I
Just
don't.
curious. Okay.
A couple of questions. When you say medication management, are there clients, have you confirmed that there are clients there on, I'm assuming that's for psych meds, mental health medication?
You know, they gave me this. I should have asked them. I don't have more
Yeah,
detail.
do they have any clients or have they had any clients with, who are on medication for addiction treatment?
Yes, they have people on buprenorphine. And one of the struggles we've been having is, so the nurse is there Monday through Friday, 8 to 5, how to, handle the buprenorphine. Because our pharmacy has looked at the facility and said, nurses can only go into this dispensing room. It's not a pharmacy, but it's a med room. And so we're trying to figure out how to make sure that we have controlled buprenorphine on the weekends and the nights. They're developing a system right now. I think it's going to involve like brown bags into lockers, and only like a certain staff can access it during the non-nursing hours.
You can always, we'd be happy to consult because obviously we have clients on medication in residential programs.
Yeah.
And none on methadone then.
I don't know.
It would be helpful to know if there is a restriction on clients coming, given the medication issues.
I can tell you as a policy, the policy is that the clients on methadone and buprenorphine won't kick people out as a matter of just relapse alone. Start a fire, do a bunch of other stuff. We may have to look at that differently. And in terms of the requirements of being flexible program, there's only 2 requirements: is that you attend a kind of a morning and eve community meeting, because it's a community milieu-based environment. There are lots of services and groups offered in between. Actually, numerous. It's very, very dense curriculums that are available, but they're voluntary in terms of participation with regards to that.
Don't typically, so I think our clients that have relapsed, they go over to Billie Holiday for a few days and then they come back. So they don't lose their bed.
Okay.
They go to Billie Holiday like for a week and then they come back. And they've done it numerous times, sometimes during their stays.
David?
Yes.
I just want to make sure I understand the slide. Is what you're saying is that currently, as of April, right now,
Yeah, right now.
there are about 65 clients
Yes.
in the 72 rooms.
Yes.
And which of the data below that apply to those 65 clients?
All of it except to this one. The
Yeah.
72 applies to the whole since June. So I should have written since June. This is now. They actually had 35, and then there's some reason they're down to 30 now.
Okay.
Yeah, so this is the only line that is not now. This is
How about the 35 who, are the 35 who obtained housing, are those discharges?
Yes, they left.
So it's really the first 6 that apply to the 65 clients?
Yes.
Okay. And what's been the average stay for those who have been, I'm not sure the word discharge is the right word to use here, but if that's what it is, what's been the average length of stay?
I don't know yet, because we're basically just reporting out monthly, but hopefully we'll have some, there's been some staff turnovers, or going to be, and we will be just summarizing the program.
Okay.
working with the ADP's data. They're interested in, for example, were anyone rearrested? Kind of we're interested, did anybody go back to the hospital? And I will add average length of stay as there. And then we're also, how many people are have been moving through?
And is the department or someone or case management tracking the 35 clients who have been discharged to obtain permanent housing?
I don't think they've been I don't know if they've been tracking this group afterwards and how they've done.
Okay.
Is that what you're asking?
Yeah, I mean,
I don't know.
sort of asking whether there's a continuing monitoring to see how successful this has been for someone who has been through the Minna project and how they're doing on the other side.
Okay.
That's something given that it's all probation and given that it's unlikely they're discharging probation upon getting housing, they're probably still on probation.
Yeah.
That would be something that probation should be able to track because they're still under some kind of supervision, unless it's kind of a summary probation.
So the way I look at it is, when we started in June,
Not everyone's on probation anymore. They can just have been previously justice involved. So,
Okay.
But yeah, for the folks that are still on probation, they should have.
Okay.
data.
so upon starting in June, the program started to kind of level out in the last several months. We're still waiting to get a nurse. And we've deferred like an evaluation. This won't be as formal as our other program evaluations because it's most of the monies have been passed through adult probation. But at the point that we do an evaluation, we hopefully will reach a steady state. But we haven't reached that point.
Yeah, David, residential programs have held clients' medication for them without dispensing and kept account of them, and clients take their own meds, and there'll be a med line, or a med call will open, clients come in. And so it is possible, if that is a restriction, you don't necessarily, you could have nursing staff who oversee it, but program staff should be able to be trained to just, sit with a client, they take their meds as they're prescribed, and they're witnessed by a staff. But we can help with that because it shouldn't be a barrier for folks in terms of there's not enough nursing staff for their medication.
I may contact you.
Yeah, please do.
I think
It's been for-
sensitivity because many of the staff had prior, incarceration histories. Some of it's drug related. You have clients there with drug related crimes. So I think there's a sensitivity of these are, abusable drugs, and we want to make sure they don't get mistracked because that
Sure.
could be somebody's probation that's on the line.
Yes, just treatment programs have been doing it for literally decades.
Okay.
So same population, often staff with lived experience. And so so it's not a barrier. We'd be happy to we can come over and watch how kind of Medline is run.
Our director, Adrian Maldonado, has just announced that he's going to be moving on to a different place. So when that settles in, I'll ask him.
Yeah, sure thing.
David, do I have is my echo bothering everybody else?
No, we love hearing you 6 times.
Is that a compliment?
This is going to be too difficult.
We can
I
hear
got
you
kicked
now.
off the
Steve.
feed and my audio is screwed up. Quickly, how many individuals have left the program in an unplanned way, either walked away or were referred to a more intensive level?
I don't know, Steve. I apologize. I don't have that information.
What's the total number of clients that have been served since Minna opened?
This is the data that I get so far, and it's hard to get this data. And I understand the need for the sense of understanding, but I wanted to just give you a status. I don't have much more than what I'm presenting to you now. And we don't have an analyst or someone to collect the data. So it's kind of done by one of the staff members, goes through the logs. And these are questions I'll add and make sure that we address for them. Does that make sense to everyone?
Yeah.
Yeah.
It's like we need some data and somebody went through a list. And
Yeah. For the interest of time, why don't we go to the next?
next slide, please. So we want number total and number who've left.
And if
There's so
you have where they went for housing.
Yeah, where they went. I have that, where location.
It's 23. That one, yeah,
Okay,
not 24.
I'm gonna
sorry.
sit down because I think that that makes it easier for our guests to see.
Mhm.
So this is Summer Rise. I think all of you know or have seen it, like it's received a lot of publicity in the news, and it's been running now for again 9 months. I think it's been one of our stellar programs in the system as a joint project between us and HR 360. It's designed to provide a safe, sobering place for people that are intoxicated and needing to come down. It's located at 1076 Howard. We've just redone the front with some screens, so it's not on this particular picture, but the building and the inside is quite nice. Next slide, please. So the following are these are recommendations that you had given to us regarding Summer Rise. This slide were about services. I'm not going to go down the list. Next slide. And the next slide were about community engagement. We're in the process right now of an evaluation, a formal evaluation with Harder and Company. This is a $75,000 evaluation, so it's going to be substantive. We'll provide quantitative data, qualitative interviews. We'd like to capture the history of Summer Rise and lessons learned. The lessons learned, I think, are important because as a low threshold service, going back to the Tenderloin Center, now Summer Rise, and maybe some of in the future, if there's wellness centers, there's lessons that are common to all of these low threshold programs, and we'd like to have that as part of the evaluation as well. So I'm not going to address those, and I'm just going to give you a snapshot. This is a little better data. It's out of the EPIC system, but we haven't really audited it, and so we'll when we do the formal evaluation, which we hope to get out preliminarily by June, at least in terms of talk points, and maybe July, August, something written that would be more formal. So we're averaging at Summer Rise over here. This is March, the month of March, but it's averaging about, this is on the lower end, 750, more 850, 800 to 850 has been the monthly average on the program. And so you can see that accounts for about 170 to 200 patients or participants a month. They're not patients or clients because this is not a clinical service. They come from many places, mostly walking in. What I want to highlight here is that the number of referrals from street crisis, which is here and here, are not insignificant. We get 2 or 3 referrals a day from the street crisis when they were deep with DPH and now with fire. We've actually worked out a very wonderful arrangement. While the unit has 20 beds, we keep 3 beds aside every night for the fire services. That seems to be the right number. And every day now, whenever fire has someone that's intoxicated, that's appropriate, they drop them off. And we meet, we were meeting weekly with fire. We're meeting about every other week now with the fire department. And they've been very, very satisfied with the service. During 420 Day, we thought it was going to be as a national holiday in San Francisco. We went up to 5 beds because we thought there would be a lot more problems, but it turned out it wasn't. Although I live in the Richmond district, which is close to Hippie Hill, and a lot of traffic, and you can smell big cloud of smoke.
That's good. It was hazy.
Yeah, it was fog, right?
Hazy.
Right, MOG. In terms of departures, most of the clients walk out since they're in-house, and they go to the Soma and the Tenderloin neighborhood. The number that I'd like to share with you of importance is we were in the beginning have numerous emergency calls as the staff is trying to wonder, what's urgent, what's not urgent, and settle with the protocols. We've significantly decreased those. And currently, we have less than 1.3% of visits going to the emergency room. So I believe that we are substantially diverting from the emergency room. The national standard for sobering centers is to keep this ER bounce back rate to less than 3%. So a 1.3, I think, is tolerable. That's 10 over the month out of 800, 850 visits. And when you look at the list, because we do review the logs of what they were, they are rather serious. Somebody who chronically, incontinent, severe chest pains, vomiting, on the self, sometimes having wounds. They have been really serious. We have worked out a close relationship now, a very formal or formally informal one with Maria X and Martinez Clinic, and we have direct shuttle. I understand we're sending about 50 clients a month to Maria X Clinic, which we think is a really great relationship. And now we have Door Urgent Clinic going to meet with Maria X, and I call it the holy triangle of Sobering Center, Door Clinic, and Maria X. And we've been trying to initiate this from Door. So Sobering Center has met with Door staff. Sobering has met with Maria X. This coming week or next week, Door will meet with Maria X. And we have a shuttle, a community forward shuttle van that I hope to reconfigure to maybe circulate and provide some transport around this, a triangle of crisis services all in the summer. Yes, Allie.
Thanks, David. I'm just trying to see on that departure destination. Maria X isn't listed, right? So maybe that's under
here. So in our linkages, so I think it's this medical.
Okay, I think I'm confused between departure, destination.
Yes, departures is yeah. These were formal linkages that they're saying to services.
Okay,
These are kind of walking out, and I think what they're saying is, ED is
okay, or
unwanted departure.
large number of others. Okay.
How do you know, for instance, that they went to Soma or the TL, that part?
They're asked on the discharge.
Oh,
Yeah, so
you asked.
we have a
Okay,
large
got it.
number of others that don't know.
Yeah.
Yeah.
Okay, cool. Yes.
So
That's my question. What's the
where are you going? I'm gonna,
other and the unknown? Because you have a section that's other and a section that's unknown. So I'm presuming that the unknown is the folks wouldn't tell them, but that the other, they actually told them something?
Yes.
Okay.
But others, they don't know, unknown, I don't know. So one of the things is we built an epic chart because we wanted this program to be capturing services. And one of the nice things about this program, as we have just been accepted as a CalAIM community supports program, which means we offer low threshold services to link people to care. So San Francisco Health Plan has recognized this for CalAIM. One of the benefits of being EPIC centered is that we can then link people to CalAIM. Unfortunately, we borrowed an EPIC template from the alcohol sobering, which was very medical. And they've had fields that are kind of undefined. We were using medical respite. We were using some other fields. So the staff is still sorting out what these fields mean. And I believe by the time we get the harder evaluation, that would be the report I would really rely on for this data. This is what we're getting kind of out of the Health Rights EPIC. And I'm not sure what the staff is using for. That's why I said it's kind of unvalidated, unaudited the data. But let me go with one thing, Hallie, if you don't mind. The thing we're really proud of is we've gotten 107 linkages out of this month. And the number of medical linkages to Maria X are significant. The number of detox referrals have gone up from 1 to 2 a month to 20 a month. So for me, these two are really significant. And of course, case management services. I'm not sure if this is the OCC. We've been trying to better coordinate with the Office of Coordinated Care as they drop off people, for example, the BEST team, picking them up in the morning. That's a procedure we haven't quite worked out yet. Mental health, I think this might be Door, I'm not quite sure. So this is significant. We've just learned, the staff is learning, oh, I'm supposed to record this in the linkage box when I do this. Yes, so some of this is we're collecting better data, but some of it is we actually are making better attempts to link people and give them the right script of how they get on. When they do go to treatment, they have the shuttle that's around the clock, that's right in front, just drives them over in the morning, and it's worked out really, really well. Allie, go ahead.
Yes, so given that the original vision for Soma Rise for drug sobering came from the meth task force and also just the urgent situation with psych emergency at ZSFG and the number of people who were there for problems that could be addressed in a sobering center better. What, is there any, I mean, I know you pointed out the 1% departure to ED for the really serious medical conditions, but is there any way that you could imagine us collecting data to try and quantify whether Soma Rise is meeting that objective of diverting people coming in, diverting people who otherwise would have gone to psych emergency?
I think that means tracking meth and then tracking diversion.
It's really, I'm not sure. I'm not thinking of it. I'm just sort of asking the question, like, is there a way we could evaluate whether we're doing that, meeting that intention?
Okay. I understand. So what I would say is that from the field, we're getting it qualitatively. I don't know if we'll have quantitative. I think there's been really wonderful input from first responders saying, this is a program we've needed. And I think you'll hear that they will say, this is definitely meeting our needs. So the triage, at least from fire, is happening on the street. And I think not at the facility. Does that make sense? But I think that that's the way it should be happening. So there's not a double triage or a re-triage.
And my last question is just about capacity and is demand well matched right now to the capacity at Soma Rise? I mean, that looks like a lot of people, like 20, up to 25 people a day or so that they're seeing, but is that what they, I know the number of beds is something like 20, but people cycle through. Are they often close to new people walking in? Are they conversion?
I think it's been more closer to 30 people a day. Where there's been from the beginning there, like during the rainy season, a contingent of people that hang out, know when the changeover is, and go in and have used the program as like a shelter. So the staff has been active in identifying them and saying, look, this is not a shelter. I know you're intoxicated. There are other people that need this service as well, and you're not in crisis. So we've tried to set up 3 different levels of priorities. We definitely want this program to be low threshold, meaning you can walk in, and we are getting that in every way. There's no barriers to walking in if there's a bed. And you say you're intoxicated, we say, okay, come on in. The second thing, though, is we wanted to make sure we had enough room, maybe the census for questions, to meet the needs of people in crisis. So, yeah, so that's why we don't want people that are stable there, just like, kind of like, I don't want to say bricks, but I'm going to say bricks that need to move on to housing or some other services so we can make room for people in crisis. And then the third is that people in crisis is, we want to make sure that we get those that need and want linkage to be linked. And so these are the operative goals. And that issue of low threshold versus crisis beds, that's something I think we've worked out and find the right match. And we're really now focusing on getting those who need to move on till the services moved on. So that will come out in the report. I think you'll see some of the history of that development that the staff had to go through. Okay. Next slide, please. So I'm gonna move on. Tell me if I'm going too long.
I think we have, how many slides do we left? Yeah,
I'll move fast.
Yeah.
Okay. So residential step down through a contract expansion. We opened 70 beds on Treasure Island. It's right over here. Very nice neighborhood setting. That will stay there in a transitional form until we do some remodeling on Treasure Island. But right now there are 70 beds, providing up to 1 to 2 years of transitional housing. I heard this morning they have currently 16 beds open in 2 of the houses. There are a series of what do you call them? They're not bungalows.
Flats,
They're flats?
like townhouses.
Townhouses, yeah. Series of townhouses. They got 2 of them open. And as they get more staff, they're open like another 3 or 4 to get us up to the full 75 beds. We expect the full 75 beds for June, July, August as staffing rises. Staffing has been the hardest thing on any program that we've launched in the last 2 to 3 years. Any questions about Treasure Island? We see very positive news from the Chronicle. The mayor felt that this was really one of the best investments to be in a nice sunny area outside the city to move towards, again, education, employment, and permanent housing. She was very happy with this.
It's funded by Prop C, right?
Prop C, yes.
Yeah.
All these programs are Prop C.
Yeah.
Next slide, please. All right. So I want to give you an update on our crisis stabilization unit. We are at 822 Gary Street. The process has slowed down somewhat because of complexities around permitting. There was permitting issues around PG&E, about having the size of this huge transformer that needed 1,000 square foot transformer that we had to put into a 9,000 square foot building. That would have been like 1/10 of the building, this electrical thing. We've had more various seismic studies, and we're inching along these permitting processes. Once we get past that, we're still in supply issues around HVAC systems. This is one of the things that delayed some Rise. So we're looking for an opening in 2024, probably more to the latter half of 2024. The thing that we're very happy about, however, is that we've applied to the state and we've received a $6.75 million infrastructure grant under BCHIP 3. And this is, nice, the way to make sure that we have are making the best use of Prop C by leveraging what we have. They want the state wants the city to pony up, and then they'll pony up, and then together we'll be able to launch this thing. Right.
I know this is somewhat unrelated, but so on the other parcel behind there was that supposed to be where the safe consumption site was going to be. So is that still happening, or is that kind of indefinitely delayed?
It's indefinitely delayed, and we actually they're one building project, one construction, but there's two separate activities programs. So there is a program development team that has looked at that. We are working with the building team that are building both, and it's because the buildings are linked that's created some of the permitting issues.
David?
Yeah.
I know this is probably a later slide, but you've got a grant on the Treasure Island development, which I assume was the one you just discussed.
That's a different, so
Is that the same facility?
no. So if you go back to Treasure Island real quick, we'll just do this.
We really want to talk about the CSU, but we could.
Yes.
You can think.
Oh, okay. So on Treasure Island,
Yeah.
there's a whole redevelopment that's going along.
Okay.
So what will happen is there'll be a nice little Hilton hotel over here. There's a ferry going through. All these houses will be torn down, and then over here, we will, using, again, grants and Prop C dollars, be building a new building that is to replace the residential step-down beds that are over there. So it's a multi-use building, of which one of the floors will house those clients.
So I assume that the grant for Treasure Island and the grant for the CSU, those two different grants you mentioned,
Yes,
that they're for really construction, development and construction.
yes.
So given funding issues, is there a guarantee of operational funding?
Yes.
Okay.
So that's been calculated into both our purchase, the set asides for capital improvements and purchase, as well as operating funds. So that has been calculated in our total budget with Kirkpatrick. I don't know if she comes here.
Okay.
All right. Okay. Let's keep going past CSU. Did you have a question about CSU?
Yeah.
Next slide, please. And we're going to hold on these recommendations because there's nothing to recommend at this point other than when we get there, we'll make sure that we incorporate those. Again, we have been trying to reach out to resources and make the most of leverage. I think leverage is an important concept that we don't use enough in our public sector, but we leverage the Prop C monies in order to get, again, the crisis stabilization unit infrastructure or capital funds. Again, expansion grants for new beds that would replace the buildings that are currently there. And then this is a community care preservation grant that was specifically available for preservation of, we applied it to boarding care. I think it might have been larger than that, but we're using it to support our boarding care system. We're working with MHSF, who is developing a mechanism to be able to distribute this boarding care operators to make sure they have sustainability. It might be, for example, I have a house of 6 clients. A house has major plumbing needs to keep my program open. That might be something. I don't know if it's going to be used to offset, what do you call it? There's like their rent subsidies. I'm not sure if it's going to be used for that, but we're working with, again, the mayor's office and community development as a mechanism. We don't think it's a department. We have the mechanism to be connecting all of these agencies and managing the money. And then there are RFPs in process for these. So again, Summarize is on a pilot, so that will be RFP by the end of the year. We don't have a space for dual diagnosis yet, but we're trying to get an RFP out so that we'll be ready and lined up before we get a space. Same thing with transition youth, and then the CSU crisis stabilization unit RFPs in process. We're trying to get the RFPs so we have a vendor at least 6 months before we launch, so they can be part of the development of the program. Any questions about these? Okay, next slide, please. I think we're done.
You survived.
Is there time?
Yeah.
Okay.
Yeah.
Yeah, do we have any idea where the whole care court requirement plays into this? When we're talking about new beds and facilities, I imagine that's going to create a need for even more than we've been creating. Any thoughts here from the department about what you're going to need to do to fill that need?
There's been, so it's not part of mental health San Francisco. So, I think it's part of this conversation. But it wouldn't fit in terms of the discussion we're having, but I will tell you, there are state grants that we've been looking at that would offer an expansion of services to hopefully capture the flow that might come through care courts. But at this point, we're not really sure who or what's going to come through.
That's what I thought you'd say.
Yeah.
But I guess what I'm really, looking at or thinking about is like the pressure that's going to, create on everything we just discussed, and yeah, it's not technically part of mental health stuff, but you kind of can't separate it either, right? I mean,
I will just say we got a whole slide on it last month from Dr. Kunins. Where does care court intersect with mental health stuff?
I did not recall. I will look back at it.
So it will, because it's the same, it's the exact population.
Yep.
That's the target of mental health SF. So
it makes me nervous.
Okay, is that okay?
Yeah.
Okay. So
Reminder, thank you.
we've applied for a bridge housing grants. The governor has, I don't know, $1 billion that he's put out. We think we're eligible for some 30 million of that, and we're working with housing HSH to try to develop care paths. We believe that a lot of these folks will have been unhoused. They by nature, going to care court, may not be treatment seeking. So the priority may be moving them into more housing with supportive services. And if there are ones that want to come to treatment, well, we will just sing hallelujah. And we think we have the capacity right now, but we think it's going to be a group that will probably move more into transitional settings with wrap services. And we'll need like stabilization beds so they can land quickly as they move and find something that is more long-term. For the mental health, we're thinking that long-term might be board and care kind of situations. And we're working with HSH on their end, looking at them expanding their transitional or permanent housing. So, and then anyone that's willing to run and flow into our MHSS services, we will be very, very happy. We think we have the capacity now, both in substance use. Well, mental health can sometimes get slow. And we thought, I think we're gonna have to deal with it when it comes, because we just don't really know it's gonna come through.
Thank you.
Does that help out?
Oh, yeah, and yeah,
So
yeah, I expected that, that you're trying to figure it all out and there's a lot of unknowns. But I also wanted to just hear from you that, something you're all thinking about, which I also expected, but yeah.
Our biggest priority right now is submitting the application to get the funds, and then to begin, expanding the various points of service that we're working out with HSH, so that people have an opportunity. People want housing, and then if they want treatment, that's great. Get treatment in there. We think primarily, housing is going to be the priority.
I'm happy to hear that.
Yeah.
And if I may add, it'll be in the director's update as well, but.
Oh, okay.
We have a hearing at the Board of Supervisors on care court implementation this Friday.
That's why I'm thinking about it. Yeah.
If any of you would like to watch, it's on SF.TV. They'll have a full update from the department. Sure, quite a number of questions from the supervisors to clarify.
So I wonder if I could, geez, I didn't solve my echo problem. If this is too difficult to listen to, I'll just address questions at a later date, because I'm getting a whole lot of feedback on my audio.
If you can stand it, go for it.
Oh,
Steve, do you know that you're double logged on?
pardon?
Yeah, he knows he's double logged on. He needs to log out, get back. He's going to do that at a break. So
Yeah,
Steve, why don't you go ahead and try?
I'm going to try that at a break. But let me just quickly say two things. This distinction of what's part of MHSF and not part of it, I think has been one of the barriers in our discussions for a while. MHSF originated as a system-wide reform effort. It was about the whole behavioral health system. There was not something that was necessarily a part of MHSF, except for the broad expansion of treatment that it calls for in the ordinance. It predated the distinction we've made that we're looking for funding out of Prop C only or other efforts. So I think we limit ourselves in preparing for care court or anything else by deciding what's in MHSF's purview and not. It's about the entire system of care. And I think we need to broaden our thinking sometimes. And I'd also like to say there needs to be some discussion about this, again, way too facile decision that there's people who don't want treatment and who do. And that somehow less services are more amenable to intervening in an individual's mental health and substance use treatment needs than more services. We need to talk about treatment in a way that offers the opportunity as a part of the discussion about whether they want treatment or not. Progress Foundation runs the acute diversion programs, and we know that over 30% of the people who leave our acute diversion programs wanted treatment, but there were no beds. We're talking about pre-pandemic. The reason they didn't go into a level of care with PRC Baker or Progress or even Health Right 360 wasn't because they don't want treatment. They were seeking it, but we didn't have the resources. And just expanding our system on the low end of housing with wraparound services is not necessarily concomitant to offering treatment. So I think we need a bigger discussion about what treatment needs there are in the community and how the system accommodates setting those programs up so that they are available to individuals, which is a huge part of determining whether they want or don't want treatment. Thank you.
And could we have, that's been waiting, and then Amy, and then let's move on.
Yeah. David, to what degree are we contemplating, when we look at present state, you're beginning to approach the task force, I mean, the ordinances requirement in terms of treatment, but given the recent focus on expanding the criminal legal response to people who use drugs and enforcement around those issues, it's likely we would see a number of people kind of diverted to treatment going up, right? So like health rights, we're at a higher, like probably because of staffing is part of it, but we're closer to being at capacity, full capacity than we've been since before the pandemic. And so, and that's in the early days of the increased enforcement. Now, I may disagree that enforcement brings people to recovery. I don't think it does, but it does move some people into treatment. It also means that sometimes those people are more likely to leave treatment unexpectedly and or use drugs in treatment. But all that aside, we're likely to see an increase in demand if legal pressures continue to be applied. And so I just want to, it's just sort of putting it on the radar that sometimes we make plans based on prior experience and then the conditions in the street or community change. And even if it wasn't an increased enforcement on people using drugs, there is increased enforcement on people on the drug supply, likely. And I think, again, all of those conditions may have an impact on the demand for beds. And we're fairly full now. I mean, fuller than we've been since, partially because we don't have to keep isolation rooms and quarantine rooms and all kind of stuff we had to do during the pandemic. But it's just something to kind of put on the group's radar, is something that we should track and think about how that impacts planning for the future.
So our next, I understand what you're saying about being full, because you and I are dealing with that right now, right?
Mhm.
Our next, we've moved forward with a second bed optimization study. We've contracted with Mosimtech, who did the first bed optimization study, and we've actually expanded the number and scope of data points and resources. So we think we'll have a better study, and that's what we're going to look at as the next iteration of bed needs. I know it may not address like real time. We'll be looking mostly at the 2021 year, calendar year.
That's a bad year. Well, it's a bad year just because.
We got half a COVID and half a non-COVID. So, but that was where we tried to, last year's not done. And then this year, that's the best year that we had. So when that gets done, which we think maybe around August, we can come back to you and look at some new estimates of beds. But I understand what you're saying about being full at this point.
And we do need to move on. Amy, did you have?
I just wanted to really kind of, I'm glad that these folks are, we're capturing it, they're coming in, they're going somewhere, and it's really impressive to show that, the permanent housing is, pretty high. I like that. But I kind of also want to look at where people are getting treatment. I mean, I like these people getting in, sobering, and going out somewhere and staying safe. But I think the ultimate goal, I'm always thinking, is can we actually get them into treatment, and therefore these beds are for other people who might, can benefit a short term, but then ultimately the long term to go into treatment.
Are you talking about the MINA program?
I'm talking about the MINA program, the sobering center, the new bed facility. I mean, I like these things, so we're, you guys capturing it, but what about in the long term goal? I mean,
So you're talking long-term tracking and longitudinal understanding of where these people are going and if they're cycling back in or if new beds are opening up for new folks. Yeah.
And I think it's along the line what Steve was saying that, these people can benefit from treatment too.
Yeah.
Yeah.
So the study will have a methodology where we won't be tracking, we'll be extracting hypothetical individuals that are going through the system, because everyone goes every kind of which way. It's hard. And looking at the flows, and based on the flows, where we are not having the kinds of services that we need. That's the purpose of the Muslim Tech study. It won't tell you on an individual level, but it'll tell you as a system where you'll need services.
Can I ask this is hopefully to be a simple answer. So with the program, the residential programs, I harp on this a lot. So with when is there a date when Joe Ruffin, Grove, Schrader, I believe is closed? I think it's mostly probably staffing. Is there a projected date when they will reopen?
My colleague, Yun Jung Kim, is kind of managing all the residential beds. So I actually don't know that, because that's sort of, this is the new beds, and that's sort of an ongoing maintenance issue and contractual issue. I haven't been part of that conversation.
Is there a way we can get that? I mean, because it's very important. I mean, it is the beds, we're losing beds. I mean, so we're building beds, but we're losing beds. So is there any way we can get that?
Yeah, maybe I would ask
into our
Valerie
in the
to
future.
respond.
I say the department's heavily engaged with Baker PRC on their sustainability planning, right sizing, stabilizing. So all of their properties are part of that planning. I can follow up with getting you some information.
And I just want to kind of piggyback on that. And that's, I think, been asking, for the existing programs, how we can kind of either get back from what I'm understanding and remember Salinas is talking about, and how do we enhance what we have? And quite honestly, I was trying to go online, Jennifer, that try to look at those the providers. I couldn't access the actual, really
You couldn't look
little-
into it.
little blurb of what they do and what they, so I was having difficulty.
Yeah,
So,
yeah,
I mean, so I think I'm kind of looking at what do we have that actually worked before, and how can we, and, are we going to get some of those programs or treatments back, and, maybe the continued care for some of these new programs that are already opened. That's always been where I kind of vision.
Yeah.
And that's why I always ask for the mapping. I kind of come back to that, sorry, but I just have to put that in there.
Thank you very much. It's so nice to see you in person rather than on the screens.
Yeah.
More fun.
Go Warriors. Steve, thank you so much for, got bumped a number of times. Thank you so much
Did you
for.
have a comment for him?
No, not for, I mean, you can go. For new beds. He needs to leave it, but David can leave it.
Oh, okay.
Yeah, because.
Okay.
But then we're going to open up to
Thank you.
public comments from new beds and facilities, if you want to stay or go. I'm opening you the option.
Wanted to hear if there's.
Okay.
So that's the next, yes, thank you. So members of the public who wish to provide public comment on this agenda item, which is discussion item number 4, new beds and facilities, are invited to participate in 3 ways. First is in person, and I could call on people in person. Then I can call on people who have their hands raised, who have joined online. And if you're participating online and would like to publicly comment, please raise your hand now. We will call on you when we get to that point. Then we will call on those who have joined by phone. If you have joined by phone, please follow these instructions to make a public comment. Call phone number 415-655-0001. Enter access code 24825961324. Press pound and then pound again. Dial *3 to line up to speak. A system prompt will indicate that you have raised your hand. Please wait until the system indicates that you have been unmuted, and then you may begin your comment. Please note that all public comments are limited to 3 minutes, and I will give you a 30-second warning when your time is nearing completion. we have anybody in person who would like to make a public comment? Yes.
I wanted to ask, so particularly in the beginning of when Sober Rise opened, it's gotten better now, but I have had multiple experiences with clients coming and being found to be too acute and inappropriate client for Sober Rise. And then they're in the beginning were just kind of left to need a higher level of care in the street. I'm wondering what data is being, and I know you don't have the data now, but I'm wondering if that could be added to the list of data that's being collected of clients that or participants that show up and are turned away, and for what reasons they're turned away, and what, you know, what that looks like.
So, so let me ask you to turn that into a statement. We're not allowed to, we're not allowed, but by protocol, we
In
don't.
my opinion, it would be beneficial for them.
Dr. Katie not to respond, but I'm glad he's here and is hearing your comment. That's great.
Sorry to, for a facilitation note, I hear that those of us who are away from the table are harder to hear. The microphone's in the table, so.
Do you,
Any further-
would you be up for repeating your comment so that everybody? Thank you.
In my opinion, it would be beneficial for data to be collected around participants that are turned away from Soma Rise due to needing a higher level of care, and where those clients are going or participants are going, and if they're being connected to a higher level of care.
Thank you very much. Anybody else in the, oh, sorry.
No, go. Any other in-person comments? Anybody who has joined online with their hand raised? I do not see any hands raised.
Yeah, so far 0 attendees.
There's 0.
Oh, I see.
And there is nobody joining by phone because we would also see them with a hand raised. So there are no more public commentators. So the public comment is now closed for this item.
Thank you, Diane.
Thank you all.
Thank you, Dr.
Thank you.
Okay, and so now, if Dr. Cummins is with us, we'll go back to discussion item 2 before we take it.
It's like 10, I think, hands, Haley.
No. Okay, okay. So so Dr. Cummins is not with us yet. Would people prefer to take a break or to go back to the item that we started on about how we organize ourselves for these meetings? Should we go ahead and do that and then take a break? And then Dr. Cummins may be available to join us. Does that sound okay? Yeah. Okay.
Kaylee, slide 23.
Okay, so, and then, so member Short, added the item on input, of members, developing the agenda, as, one of the meeting challenges. The slide we are looking at, I think it's a previous one.
Yeah.
Could we go back up? It's on the challenges we've.
Yeah, are there-
Yeah, okay, so member Short offered one additional one around members giving input to developing the agenda. What other challenges do people have in mind that we should be addressing as we look at this item of how our meetings are structured as we go forward?
If you lost Steve, he's probably going to come back.
Okay, so I guess one thing I would add is that I think we have a structural problem with appointed commissions and working groups that people are asked to give a huge amount of time without compensation in the city. I don't think that's something we can change, but I just want to note it. And I think it really makes it very hard for us to retain members. I think when we're mandated to have members with lived experience or to work for who work or, you know, other folks, it's just very, very hard to keep a diverse and representative body with that that problem in the city. And I will continue to just elevate that in hopes that at some point that changes and we're able to compensate people who serve on these really important commissions and working groups with it, so we can compensate them for their time.
I think that's great. Thank you. I think there's a challenge with understanding the impact of the work of the work group. For me, there is, I'll say. And so I understand the work that we do, but it's very difficult to determine whether that work has impact. And I don't have a complete solution to that other than potentially hold up, or maybe to have more direct conversation with the department on feedback on recommendations that the work group makes. So the work group makes recommendations, and it may be that the department knows that it's not feasible, it's not within the scope, it doesn't agree.
Yeah.
It's not going to happen. So then, okay, you've made recommendations. So that's that group. And then there's some things that, like, did the recommendations have any impact on the outcome?
Yeah.
Did the work group change the mind or the direction of any particular project that the ordinance is it kind of falls under the ordinance? That's just for a sense of like there is impact. There's a reason to do this. Other than, like I said, now that we're in person, it's like relationally, it's great, and getting to I learn from the experience, but are we making an impact? And so I think that would be helpful, I think, just for the members and maybe for the community that listens in. Like, how does it matter?
Can I just ask for clarification? So like did you see those slides that show the recommendations that we've made?
Yeah.
Do you see any process that we can put in place where we ask the domain leads who report to us, as they update the working group, that they reflect directly on
Absolutely.
the recommendations we've made, how they've been incorporated? I mean, Dr. Bading referred to that, but do that more formally.
Mhm.
And then also, I think that we have been fairly data free in these meetings, and there is data that's being tracked as part of mental health SF implementation, and so figuring out some format by which the domain leads could share. I mean, the data is sort of woven in a little bit,
Yeah.
but we don't see updates on the key performance indicators.
Yeah.
And the key things that are being tracked.
Right.
Those may help.
No, I agree. I think both of those recommendations are good. And that's exactly kind of what I was thinking. It's like, so we make recommendations. In the future, if there's an opportunity to make recommendations, I think it would be good to get feedback on them from the department saying, that's a great idea, but it's not within our scope or purview. We're not gonna do that. So we just sort of X that out and say that's aspirational. So, but we don't need to do that. Or maybe we can do it now. So to track against recommendations, I think would be great and helpful. I think the one area that related to data is that have the work group give some input on various evaluations. So there's an evaluation design for some of the projects, and the work group might have some things that the work group advises thinks that's a key indicator of it's a metric we think should be focused on. And so that way you're getting feedback. So the work group says, we think this element of this project is important, and we want to hear how that's going. Then you're getting feedback on how the actual project is going. So I think those things will all be helpful.
Member Salinas.
I think I appreciate around the data, because I recall asking for data in particular around skirts, like things like how does this lead to reductions in arrests, and I think we don't ever get, like, I think it's talked about, but we never actually see the data after the fact. So we don't even know, is it actually being tracked, you know? And so I think everything that you're speaking to is about transparency, right? And so just having a higher level of transparency. So it's good to know it's actually is being tracked. Like, and it also relates very much to our ability to prepare and have if we had data that we could provide more useful recommendations.
Yeah.
then, right, you know, so all in all, it's like we're just kind of operating in the dark in a way, and we don't know we don't have the data to make useful recommendations, and we have no idea which of our recommendations are even relevant. Yeah, so it's kind of just an overall, more of a cooperation, a collaboration.
Mhm.
So I appreciate
There,
everything.
there is a skirt dashboard. Do you all, do people see that, the skirt dashboard, or could we figure out how to share that monthly
We
dashboard?
did see it.
You mean the reports that are?
Monthly.
No, the monthly dashboard that gives the skirt date.
The one that they sent by email, or? is
Yeah,
it-
that's what I'm-
Yeah.
Yeah,
I don't think it told us, like, because I think originally it was designed to be an alternative to policing. And so those markers, I mean, they don't track any of that data,
yeah.
or they track other things, which is like what, you know, the encounters and outcomes of encounters, but they never tracked if there was any relevancy to actually, you know, decreasing in arrests and homeless folks in jail, for instance.
Yeah, it didn't have month over month either, which I felt like it was only for
I
20
know,
roll-ups.
it's snapshot.
Yeah,
Yeah, snapshots, yeah.
for roll-ups, you know what I
Yeah,
mean? And
yeah, it
so
doesn't
roll-ups
show any,
yeah.
show any trend.
Yeah.
Sarah?
Well, we're talking about our meetings and the group. I think this fits in, but I think that it would be useful if the fact that we exist is promoted more, and that there's more public education about that we exist, why we exist, what we do, and particularly the meeting information and all of that. You know, we're always asking for public comment. We're not going to get a lot ever unless we actually ask for it, you know, and actually let people know. And still, we may not, because once they catch wind of how these meetings are, you know. But the more we can do that, I think that it would also allow us to have a little bit of broader impact when it goes talking about, you know, what is our impact? We're thinking, you know, in terms of influencing, or in terms of with department staff, but also what about, you know, on the public, and, you know, so, and that may also look like better ways or ways, period, of reporting out. Not, you know, our whole long minutes, but, you know, little blurbs now and then we do, just, you know, or, and that would also be helpful, I think, when we actually have vacant seats, recruit new members, that people have even an awareness of that we, you know, who we are, and why they might want to get involved and all of that. And so I know that that's probably not like the top priority thing, but I think it would make us a more robust body, you know, altogether, if we were doing that. And I know that there are people that I think I might mention it or whatever in a meeting, or just in general, like would be are frustrated and disappointed to learn, like, wait, what? There's this thing? What are you talking, you know, and would appreciate knowing more about it. Who's going to do all that work? I don't know.
I do appreciate the meetings in person though now, I think it's more discussion.
Totally.
100%.
Much better.
And the food.
Nice.
Yeah.
Kaylee, would you go to the next slide?
Yeah, put coffee on that. Oh.
Good to know.
Thank you for sharing.
Interim Chair Hammer. Could I take these two slides?
Absolutely.
These are some of the things that we started thinking about that we might be able to do, and wanted to present them to you to get your feedback, and then think about also some of the additional things that have come up. You know, one thing is trying to figure out, now that we're in person and we haven't had a technology glitch today,
Oh,
So
Other than it took you many hours.
You know, but we're trying, I think that what we're trying to do is get to a more doable meeting schedule of 4 hours. It's a lot to ask you, particularly given, you know, what Hallie was talking about, like you're giving your time, you're busy. So is there a way that we can get to, today we're trying to get to 3, we're going to try to keep on chipping away at it, hopefully getting to 2. I mean, that would be a much more doable, I think, for most people to have a 2-hour meeting that really focuses on the environment for a rich discussion rather than kind of talking at you. So that's what we're trying to figure out. So we came up with a couple of ideas. The city planning team, we're putting these ideas together. And Valerie, I'd invite you to like chime in at any of these.
I have a couple.
Okay. Okay. So I'll just go through them, then we can come back. You know, one is like the early receipt of preparation materials. So, you know, we get it 3 days before we get you the agenda, and often the night before you get the PowerPoint. So we're working internally with DPH to push all of those schedules up. So you get it a week in advance so that you have a full week to read anything that comes out, the PowerPoints, if there's any, like, you know, if it's the SRCT dashboard or whatever it is, you know, you'll have those to look at. That's connected to a longer range agenda planning. So really thinking about like what's going to happen over the course of the year. What does DPH have coming up with each one of these threads? Where are those marker points? And they'll shift. There has to be lots of grace with all of this. But at least we're thinking ahead and everybody is aware of what we think is coming up, and we can always adjust, but together we're kind of tracking that. And if you have something hot, go ahead and interrupt me, and otherwise I'll just keep going. Providing contextualized and timeline components. And so that's really like, and David started to do that this meeting. Like he really established, here's the ordinance. This is why we're doing what we did. This is what we've done in the past and come to you to talk about. And now here's an update. And so we're working a little bit more on that format. And so your point of like the data and reporting on the KPIs and different things like that, that can be integrated into some of these things, but you'll kind of have like a standard way of getting some of this. And if we get it all to you a week in advance, the assumption will be everybody's done their homework. And so we're coming here to talk and do the work instead of updating each other on what the work is. Yeah, and so we wanted, there's also, and I think that the in-person has kind of fixed this. Steve, you're back?
Can you hear me?
Yes.
Yeah, but the echoes there, and I can't turn on my camera, so,
There's still 2 of him.
There's still 2 of you. That's so weird.
yeah.
Mute one of himself.
But you know, your sound actually isn't bad.
Yeah, you're not echoing anymore.
Oh, okay. I'm echoing to me, but maybe it's that other guy. Yeah,
Tell him to mute one of
I completely shut down my laptop and rebooted it and came in like I was starting all over, and it's still here.
Sorry. Okay, so I said I solved all of our technology problems, but I obviously solved.
I'll just listen.
One of the things that I think, as I mentioned, the in-person meeting really has kind of, I think, addressed some of this. When we were in person, we were kind of going person to person. It was kind of like round robin conversation. And so it didn't make really a discussion very easy. So one of the ideas we had is, and again, the in-person thing is kind of fixing this a little bit, but also we were thinking like at the beginning when we're going to do something like responding to an ask of DPH or wanting to give some kind of comment, is just giving people quiet time and Post-its to write down what your thoughts are, initial thoughts, and we can group them and see where the energy of the group is and have a concentrated conversation on that, and then move through and kind of use that as an opportunity to just do some kind of intentional thinking together about what we want to do. That might help. And then, and Sarah, you mentioned this is like, you know, developing shared agreement about topics of interest for future meetings. So DPH is going to have these plans that they're rolling out. They're going to have ideas of what they want to do when and what they can bring to you, but you will also have ideas. So there's an opportunity. We're going to practice that a little bit today. There's an opportunity to say, here's what we think is coming up. Here's some possibilities. And then you'd have a chance to say, and we want to talk about this, or maybe we should swap this out. So there'll be that opportunity for a little bit more co-creation. I have one more, and then there's an in-between meeting. Don't go there yet, Haley. There's another slide on what to do in between meetings that might help. But just for the meeting time, is there anything that comes, like, do those things sound like the right strategies to do, or would you suggest some other things that would be helpful?
I mean, I think that a lot of program development has also had to do with the dollars, right? And I don't think we've never gotten information about the Prop C money and like what has to be done by what time because of budgets. And I think really having a more relevancy, I mean, because the money is what, the money, and we've never, ever gotten that information. And I think we've also asked for some maybe more direct collaboration also with the OCO oversight folks. And so I think also getting more information about the budgets and the timelines for things, because that's actually what takes precedence. And so that's why that rolls out. And then we're just like, we feel like we become an afterthought.
Yeah.
Because things had to keep on going.
So one thing I'll say is like, today, when we were talking about what would go in the agenda, they were ready to bring Prop C here. And I actually said, let's don't do it this time because of timing.
Yeah.
And it's going to be the ongoing issue. We don't have, we're trying to get down to 2 hours. So I think it's going to come back next time and it'll be something that we can talk about as a group that is prioritized what we want to talk about at the next meeting.
Yeah, help us understand how the dollars work so
Yeah.
that we.
Yeah, got it.
Yeah, I'm not sure this is within what we're talking about here, but I always go back to the ordinance and our duty is to advise on the again here. I'm on paragraph 2 on the design, outcomes, and effectiveness of mental health SF. And it seems, and I've not been part of this group I've only been part of this group for about a year, but most of our work has been on the design side. And there's not been a lot about outcomes and effectiveness. I know this came up today and I thought it was a good discussion, at least in terms of I like some of those ideas. I think design is something that clearly arises from the department. And then we look at it and then try to make recommendations within the design. Outcomes and effectiveness is a little more complicated between trying to decide where we want to put our time and our energy into. And secondly, how do we go about doing any kind of evaluation of outcome and effectiveness? And it seems that requires a more two-way conversation between the IWG and the department, with the department and the IWG, or however you want to phrase it. Because we don't have the power to initiate a study or retain consultants or somebody to do that.
Yeah.
And I think that's one of the questions I have about long-term, if we're going to have any impact at all as an IWG, we have to begin to look at, all right, with everything we've done, how are we doing?
Yeah.
What is the larger benefit to the population as a whole? And I think that's something that concerns me as to how we can do that.
Yeah, and I think, like, I'm testing with you, like, I think some of the structural changes that we're thinking about with where DPH comes and focuses on different components, if we include the KPIs, the update on the recommendations, some of those things, I think on a component level, I think that will address that. But I think the larger picture is also about the analytics and an evaluation of mental health as a whole, and they're prepared to come next week.
Yeah.
Or next month and talk to you. So when we get to the future agenda, like that'll be something that we can talk a little bit more about what you'd like to see in it.
To me, component by component is more manageable. There's just no question.
Yeah.
I mean, I don't know how we do
Yeah.
a comprehensive assessment unless we make that a goal.
Yeah.
We have life until 2026.
Yeah.
So we've got time to figure that one
Well,
out.
and I think that, again, the analytics and evaluation team has been working on some of those ideas to bring to you, and so I think that those will be things that we might be able to just have a little bit more conversation and prioritization.
Yeah.
I just, I want to,
See.
yeah, sorry. Hello. We are working with very low staffing at analytics and evaluation at the moment. So I do want to put a little bit of a caveat on that I want to confirm that they're going to be able to come. So that's a little bit to be determined. So, and I have a couple other things to share from our planning, but I don't want to get ahead of members. I thought there was another couple hands.
I just had a few. I think it'll be really challenging to get to 2-hour meetings. I just want to put that out unless we went to 2 meetings a month. I think so some suggestions I have. I think the beginning stuff, so starting on time and then going through those, the minutes, the call to order, the excusing absences, the meeting objectives. I think we should set a goal of getting through all those within like 10 minutes. Like let's set an aspirational goal and let's just, I mean, there's no value to, there's no value to any of that to the public or to the people we're our target population, right?
Is
So
consent agenda a possibility? So you package that and ask for
let's
public
look
comment?
into that.
Yeah.
Yeah, let's just look into that because each of those calling roles seems like such a waste of time. I think we also need, if we're going to cut down on the meeting time, we need to commit to preparing for the meetings, reviewing the materials, which I know is hard to do. And then I would say we should give some sort of standard work to the presenters so that they're really, I mean, sort of like what you all have already been mentioning is just making sure they're getting to like the key issues, that they don't read the slides. The slides should speak for themselves, for the public and for us. And just really highlight the key issues and the areas where we're going to be discussing or where they want our input. So that's I think those things would sort of tighten it up. Because again, now that we're in person and we're all wanting more discussion and giving more input, I think those are the things that would sort of streamline the time to be used more productively like that.
I think on top of that, if you get the agenda if you get the slides in advance, members can send some questions in. So that the.
And that's what
presenters
other
are
commissions
prepared.
do.
Yeah, so that
you're
they're
expected to.
so that they're prepared immediately. And that it doesn't mean you can't have questions when they're there.
Yeah.
But there's some things that are going to be asked. And
Save
they-
time, yeah.
Yeah.
It might be helpful if you, I'm sorry, go ahead.
Along with that, like the data, I mean, again, going back to the data, I mean, like if the department is planning certain programs, it must be based on data, right? And so if we can get not just the slides, but the data upon which they are making these program decisions, because I think, say, which is the point with the summarize, I think that I do recall bringing up that we're going to have more acute folks, when we had those discussions that, aren't going to meet this criteria of not being, of being suicidal and whatnot. And so, but this is the decision. And so what target population then, to be clear then with us, what target population, that is going to PS redundantly are you focusing on so that we're clear, is this going to be, I mean, they're full, they're effective. So then what's still then the solution for this population that are missing? So what, so that we understand, okay, maybe what should be then another idea around what we're doing for this. Yeah. I mean, those sort of things and this is where, again, we need the data in addition to just the slides.
I wonder.
Want to make sure. Yeah, okay, go.
So just really quickly, I missed part of the discussion, but on a very specific level, there was a certain familiarity to the decision that was made on the bed optimization report that we're pinning a lot of hopes on. To base it in a year, I think Vitka said it when Dr. Padine said they're using 1920 as a basis for understanding bed optimization challenges. It's the wrong year.
2021.
We need a baseline before COVID to understand where we were, and then we can comparatively look at what the COVID experience did to that baseline. But we're already struggling with a very poor bed optimization report the first time around. And this one's got to be more comprehensively understanding what the bed situation, the 24-hour bed situation is in San Francisco. And 1920 is the wrong year to base it on.
Yeah, it's at half capacity. I mean, intentionally.
Yeah,
Yeah, I mean, that's not useful. I don't, thank you for that. Like,
Yeah.
that's not useful. We're gonna be planning for the next X amount of years on something that was the least optimal year. We can go back to 2018, 2019 then.
So can city planning team take this feedback back to new beds and
Yeah.
facilities? But I don't think.
In fact, I think he said it was 2021, but.
Yeah.
well, that's even worse. That,
Fiscal, I thought he meant
Yeah.
fiscal year 2021.
2021,
20.
yeah.
And I-
the year-
Take that back to.
And just so I clear, yeah, to match what he said, that was the most recent available, and just to emphasize, the feedback is that it may be the most recent available, but
It's not a
the
good
best.
baseline.
Yeah.
Mhm.
leads us in the
Let me just
wrong
do-
direction.
Do a time check, because we have a lot left. We have the SCRT update, the resolutions, and the director's report. Are we thinking that we're not going to get a director's report?
At the soonest, Dr. Cannons will be available potentially at a quarter after,
Okay.
soonest.
Okay, so
If we need to forego it in the interest of time, that may.
it's just that it's connected to the other.
So why don't we have two more slides to make through
Okay.
for this and then.
Okay.
Haley, if you
And
could-
then let's leave 5 minutes for,
Um,
we'll break at 10 after and do a quick 5-minute break.
Sorry,
And then, yeah.
I
wanna go
wanted
back?
to add.
Oh, sorry.
Yeah,
yeah.
Thoughts very briefly. I know we're short on time. A couple of things that we have considered as well as whether there'd be opportunities to form other kinds of discussion groups. And there you go. I want to note that I'm still in conversation with the city attorney about what kind of groups we can form and how.
They'd be like committees? Is that the?
So,
Not committee.
so the.
Well, like committees?
So in response to feedback that we have heard loud and clear from you guys, that, there is a difficulty in a public meeting to be able to have some of the more sort of like preliminary data and robust discussions.
But I mean, we've
Um,
kind of done that, but, or sort of one-time issue.
Right.
I think these would be an ongoing.
So I'm trying to explore a way that would be possible. It depends how we structure it. And so I think we would like to know if the idea is appealing to you guys, if there's like topics that we see that would be coming up regularly, or if this would be more ad hoc, and then I can seek some additional input on how we might approach that.
Yeah. So the initial thinking was these standing discussion groups, for lack of a better word. They could be, one idea is to organize them by program component. So like there would be basically sub-discussion groups that would kind of follow a strand and be connected to it. So that could be like the wages and staffing work we're going to talk about next time. It could be, the Office of Coordinated Care, whatever. Like, a couple of individuals are actually tracking that work and bringing that back on a regular basis to talk about it. So there's a little bit more partnership going on. And we thought that similar to the initial recommendation development that we did, it would now be ongoing. These groups would actually be drafting the opportunities, bringing them back to the IWG. So there would be a little bit more focused out meeting work to come in meeting to kind of talk substantively about that.
But the thought that whatever we call these discussion groups, that the department would be part of the discussion group.
Oh, yeah.
Okay, yeah, which is kind of a difference in what we've been doing
Yes.
mostly. I mean, I know there's some different, like a mapping and so forth.
Yeah.
but these would be more integrated.
We're thinking, so, I mean, I think one thing to take into account is what Valerie said earlier, is like the capacity for DPH, depending on what's happening, may be limited. And so
Yeah.
there may be times when it doesn't work for them to be along, and then the group, maybe like homework could be given to the discussion group to do without DPH's involvement. But the point would be, is just to keep some work going alongside this meeting so that we can keep multiple threads happening and there's more partnership and full acknowledgement that there is limited capacity on DPH. And so we'll have to figure that out. Each team may look a little different.
And there's really a possibility that we would not be allowed to do that? That wouldn't be considered allowable? Because that seems a little sort of common sense. like-
So those are allowable. The
But I don't
difference
know.
is just in managing expectations of what we can. do.
Oh,
If they're set up so that they are public, then,
Then we have to agendize, it has to be
Yeah.
a
We have to
public
yeah.
meeting, all of the.
And,
oh,
and it does, I think, put us in the position of being a little bit more formal, right, in those engagements. So,
okay, I see.
Yeah.
what you're-
Yeah.
okay.
There's an option, well, Valerie's working with them on this as, you know, the passive meeting body. It's a-
well, they're not sure that that
Okay,
works. So,
so see, so we're going through this process.
Yeah.
So also just the addressing the conflicts of interest
yeah,
in that.
yeah.
Because a lot of, you know.
Yeah.
It is
different groups like that.
complicated, and I can't say for sure that there is an option that would not be an agendized public subcommittee. That may be that's the only thing we are able to do, but the feedback I got was to determine what our interest and goals were and see what we can set up to accommodate that. So,
Interest in doing that. That means like, again, we're with that goal of getting down to more meetings, more more, like less time, more discussion focused, homework outside, coming in. Does that sound appealing or does that just sound like it's
An improvement.
yeah, okay, great. Okay, because it's still, like, we're very conscious that you're all still volunteer time. Want to suggest something you don't feel can be sustained.
Some of us get to do this within our job, so.
Yeah.
Don't feel too sorry for us.
But
Yeah, on the issue of just getting people with lived experience,
yeah,
making it
yeah,
that's, yeah,
for it to work for them, that's really important.
It's not, I mean, maybe I'm just asking the question for an ad hoc or I mean, whether it's part of this or not. But I do think kind of data evaluation and key performance indicators is at this point in our development is pretty, into the work, the group's development is pretty important. And I think, you know, having some say in what's measured and what success looks like, I think is within the scope of the group to at least make some recommendations. So I would ask for that to be regardless whether it's at some point as
yeah,
before decisions are all locked in of this is what the evaluation of this component looks like, or these are the key performance indicators that we want to be tracking. I'd ask for some work
Yeah.
around that. And whether it's after the next meeting,
yeah.
there's a presentation
Mhm.
before, you know, the timing of
Yeah.
looking out, what
Yeah.
the timing of the group's work is. But
Yeah, okay. Yeah, so one of the things we'll explore then is kind of, we'll continue to see how we can set up these subgroups. I would imagine that there'll be some of this data stuff that you're talking
Yeah.
about will probably happen within, if we're able to do those groups, it would happen within and then bringing it back for clarity to the group. So that would be what we start focusing on.
But yeah. The other thing that would be helpful, in the same regards is whenever there is, and it can be shared with us that any sort of like directives or, instructions or, you know, whatever that have, also come into the equation would be helpful too. Because sometimes, you know, I find myself, why did they do this? What's going, you know, and somebody says, well, you have to understand the constraint. They've been, you know, directly instructed to do this by such, you know,
Yeah.
and it's helpful. So in those cases when that can be shared,
Okay.
it's useful too.
I do think if we spend time outside of meetings in these discussion groups, like when we think about data, like there's a whole team just like going so deeply into the data and trying to define all these metrics and report on the key performance indicators. So I just want to make sure that we don't layer more work on top of where work is going. So I just want to figure out how to prevent that.
Yeah. I think with all, as we do more work on these groups, it's like we have to have explicit conversations with one another about what DPH's capacity is and what your capacity is, because we're trying to hit that, you know, bring those two things
And if we're
together.
focused really on recommendations, to go back to the domain groups, that might help greatly.
Yeah. Okay, last slide. Kaylee, I think it's just kind of like, has a little thinking person. Yeah, so, yeah, that's where we are. So we've kind of worked through this, you know, we'll go back and we'll figure out what's possible and bring that back. And then we'll start working on this together and just really taking it as a test, you know, of how we can make this better for everybody and continue to improve it. That's it. Does anybody else have any other? As you have more thoughts, we will be integrating them. So it's just thrown with time to comment on it.
That was seemed like a really worthwhile discussion. I think some great ideas came out of it. So thanks everybody. It's commitment to keep working on this and make our time as well spent and productive as possible. All right, so we are
Comment on,
ready for comment.
Another 5.
from chair or.
Yeah.
So members of the public who wish to provide public comment on this agenda item, which is a discussion item number 5, organizing ourselves now that we're in person, are invited to participate in 3 ways. I will first call on those who are here in person, and then I will call on participants who have raised their hand who are joining online. If you would like to speak and you're online, please raise your hand and we will unmute you and call on you when we're at that point. I will finally call on those who are joining by phone. If you are joining by phone, you can public comment by calling 415-655-0001, entering access code 2482-596-1324. Press pound and then pound again. Dial *3 to line up to speak. The system will prompt you to indicate that you have raised your hand. Please wait until the system indicates that you have been unmuted, and then you can begin your public comment. Please note that all public comments are limited to 3 minutes, and I will give you a 30-second warning when your time is nearing completion. Do we have any in-person folks who would like to publicly comment? No in-person folks. Do I see anybody online with their hand raised? See a hand raised somewhere?
Oh, I thought, okay.
Yeah. Kaylee, do you see any hands raised?
I do not.
Okay. So there are no public comments, so public comment for this discussion item is closed.
Great. All right, so we're gonna take a short break. Do people know how to access the restrooms? Okay.
Follow me. I got it
Okay.
too.
Okay, great.
Yeah. Haley, yeah, there you go.
Okay.
I'll be the Pied Piper.
We'll reconvene at 11:15.
I think she can turn off the recording, right? Or the break?
She can't.
Okay, never mind. Don't stay how it is.
Yeah.
Watch us break. Yeah.
So nice.
I don't know.
You have a meeting outside. Yes.
Not this year. The first lesson.
You know, I'm so tempted to do another car. Say, oh my God, that's hard.
I get some fruit.
I didn't prove.
Yeah.
Oh my God.
There, orange. Blueberry, blackberry. Oh, that's probably.
Wow, that's all omega.
Yeah, that was all.
Omega.
That was all I took part of breakfast. That's what every day.
Oh, that's great.
Yeah.
Healthy.
You didn't ask about the rest of breakfast. No.
Oh my goodness, I could part now. little sliver.
Yeah, you can, we can move.
That's it. Everybody's coming back in already?
Where's the partner? Can you believe it?
No.
No, it's in the household.
Here's the thing. He's got a babysitter today. There's another dog. So he's got another warm body. Yeah, hopefully that's this time.
Yeah.
I'm like trying to clean your fist.
Well, if you have no cause, then that means.
The older they get.
No news is good news.
Yeah, well, it's people too, right?
Exactly. Well, what's common? Because you say the older they get, the dogs are cookier. Like I have an older German Shepherd who's now beside me. She never did.
Yeah,
Twilight.
it's true. You think, they development, they get to maturity and that's it.
Yeah.
But no, then they start doing a whole other.
Yeah, well, it's like, just like human.
That's what I said.
regress.
People. It's
You
true.
know. I'm sorry.
He also just, he also just
Oh,
went
no.
backwards and now wearing diapers again.
Oh. See, the general nurse just died.
It's not-
People too. That's my side, you know?
It is on the board.
People who work for.
No, I actually have a situation.
Did everybody?
Oh, it's not. Be a rather crazy puppy.
Oh, no.
That I'm trying to figure out what to do.
Oh, my goodness.
Yeah. Very cute. So like, I don't know.
How old is he?
He's like a year old. But
Oh my God, then you gotta couple up with.
so I have this little baby dog and this old man dog.
If you try having them together.
Yeah, they're hanging out right now, but I'm gonna know what's.
Yeah, she said that.
What my house is gonna look like.
The older one can be a caretaker and then the other one.
He's so not a caretaker. He was, no, he doesn't want to. He wants to hang out with anybody. He doesn't, he's alone.
Well, that. I think my breakfast bring a neighbor, 72 past. Oh my. Got a whole stack. I remember this is the worst that I've ever, I was younger than that.
That's your mom.
So it's.
That's really cute. No, this guy's, he's not.
Yeah.
He's already in the grandpa stage too.
Yeah. Minors.
Yeah, but this guy's like animal. He's not a hockey friend either.
I was gonna show you, my son has a new support, a 8-pound little support dog.
Oh, that's the right side.
Yeah, he carries her with him. He's in college and he carries her with him everywhere. And we adore her. Yeah, I'm gonna show you a picture. So I can find them.
I get nervous about, because I used to have like cats and dogs, but then when it was time to go, it just devastated.
I know.
can never.
Oh, my
Terrier.
God.
Oh my God.
She's an amazing dog.
Looks amazing.
He's 3 years old and he adopted her. She was just like, we call it like, so a family just turned her in.
Oh,
Because they couldn't take care of her.
She's so ambitious.
I mean, like he sends us pictures, like he'll send us picture of like a public restroom. He carries her in a sling and he like just puts her over the, so like she goes everywhere with,
Especially.
and she's done,
Yeah.
like.
8 pounds. Oh my God.
8 pounds. And our interest in his health is just amazing.
I mean, they're great companions. They're so unconditional, you know?
Awkward. I know he's, sort of wants me to be around, but.
Yeah. There's the restroom.
Oh my God, that is so cute. Wow.
Oh,
man.
So cute.
Name is.
All right, folks.
Yeah. All right, we're gonna reconvene. Please, everybody, come back to the table and I believe Dr. Cunnins is on the line and ready to give her report. Maria, are you on? See her. Oh, that's the only list. Oh, I thought there was more people.
I know, why is it so empty today up there?
We're all here. A lot of us are here.
That's true.
Have 8 of us. Sorry, where are we going now?
We're going to discussion item to the
Okay.
director's report. If Dr. Cunnins is with us.
Yeah, when she said to pick that stuff.
Okay. Do you have a?
The only other thing is to go back to the resolutions. Is there? So, let me just talk briefly about that.
Okay. So we'll move to discussion item 3. It looks like Dr. Cunnins isn't on. So these are the resolutions. At our last meeting, these resolutions were drafted. You should have them in your packet, and we'll go to slides 1 and 2. One's a general resolution around the interaction of departments with IWG when they're making significant changes to programs, as spelled out in resolution 1. And so that was that really big appreciation to Member Lipton for his drafting of this of this wording for the resolution, which addressed the concerns raised before about sort of imprecisely defined words in the previous draft. So that's resolution number 1. Resolution number 2 is specifically about the changes to street crisis response and making some some statements about what would need to happen with street crisis response in order for it to be in compliance with the mental health SF ordinance per our reading of the ordinance. So then we got an email from Valerie from the city team yesterday, collecting input from city attorneys, is not here today, regarding the resolution. So I thought that we should probably discuss that input first, but if others would rather discuss the resolutions first, I can entertain that. But I thought we would hear the impact from city attorney just on this procedural, whether these resolutions are in keeping with our charge as the working group.
Sure, and I want to emphasize this is an independent body. This is all advisory from the city attorney. As you remember, as I said in my email, we asked them for input on what effects resolutions from this body could have. We weren't really sure. So related to that, they requested to review the resolutions once drafted. They did so. They have some recommendations they think that would perhaps bring the resolutions a little closer to the ordinance as they are reading it. And they wanted to discuss those with the chair. They're not here today in person because that constitutes providing legal counsel in a public meeting, which is not something they're able to do. They were hoping for the opportunity to discuss them with Monique. And have her be able to be the vehicle to bring that back to you guys. So the request was that you consider postponing either the discussion or a vote on it today. That was their request. Again, they're not in charge here. It's a request. So,
Was anyone an attorney here?
I have attorneys in my family.
yeah, I'm married to a lawyer that I would not comment. Yeah.
Well, it seems that they have some recommendations that might make for a more effective resolution. or implementable resolution. So it seems to be kind of common sense then to table it for the next meeting to have a more effective resolution.
Yeah, I'm okay with waiting for the chair as well.
Yeah.
Yeah, she's always here and to at least have the benefit of that conversation and bringing it back at the next meeting.
I don't think it's ever a good thing to do something in the absence of somebody who's here who should be involved. But since the chair is not here, since we have a working group on the resolutions, would it not make sense to have the city attorney advise the working group that actually drafted these resolutions?
I think that's that.
Because what's going to happen is if you go to the chair, then the chair is going to come back at the next meeting. And then we're going to have to go back and rewrite them again. And now we're looking at June or something before we probably get, probably the end of June before we get to this. And it seems that we could expedite this within the next 30-day period. So we can come back with something.
Makes sense.
I think that seems reasonable. I'll tell them.
So that makes sense. As long as Chair Lassar can be there, city attorney can, and then would people be in favor of collapsing the two? So it's not two separate meetings. We're not talking about wordsmithing.
Yeah.
We're talking about how we respond to, okay.
And I want to confirm though, we should confirm procedurally whether that necessitates agendizing it and making.
It's a small group.
Yeah, it's a small, yeah.
Yeah, and
There
I'm
are four or five of us?
Yeah.
Five with,
I wasn't trying to
Chair.
exclude the chair. I mean, I think,
Yeah.
and I don't remember whether the chair was supposed to be part of this group
no, she,
initially, but I think we still stay within the numbers that. we-
okay,
Okay.
yeah, no, I can.
Yeah.
Step out so the chair can. step.
I just want to make sure I understand, and I agree with what people are proposing here, but, so they are saying they have, concerns, not necessarily with the, I guess, the substance of it, but with the language. And
They had some suggested edits. I think they would prefer to share the nature of their edits directly and.
right, but their
Yeah.
concern about this or why they had those edits was ostensibly in service of, as Andrea said, making it a more effective resolution? Or was it anything, did it have to do with more of the, the substance, I guess, is, like,
As,
20 questions.
yeah,
Would you say that it's, but you know what I'm saying? Like, I'm just trying to better understand, like, are they raising concerns about no, this group shouldn't be advocating for this thing or, that kind of thing? Or is it more like, the way they've written this is not gonna get them what they're trying to do? Like, I can't quite understand what they're,
sure.
who they're,
I think that I'm not,
here.
They
So I-
restrict the city.
I know. Yeah, but
so again, noting, this is not a requirement, right? This is.
Right, right.
This is something that it's a request from them. I don't think because they are counsel to DPH that I'm really like.
yeah,
pretty
yeah.
clear
Okay.
everything they said with me, but they are more than happy to like share their feedback directly with IWG in either through the chair or I think I'll present the idea of with the working group. So I appreciate the questions. It's totally reasonable question. I unfortunately think we're gonna have to reserve.
I'm just looking
that
for conflict of interest here.
Yeah,
So.
yeah.
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 But, okay, so, I mean, I agree just basically based on what everybody's saying, it is what it is. I feel frustrated, because I think too much time has passed already. And, as you pointed out, I mean, it may be, Scrot or whatever, by then. That's a new name.
What?
Okay, that was it. I was trying to say it may be a whole different thing by then, like that they've concocted you all, DM, fire department, whatever.
Okay.
Acronym. It was supposed to be a whole new acronym. Boy, that fell flat. But, and then it's harder to even, get what we are asking for. So, as much as we can do this in, I'm gonna laugh, in a timely manner, the better. And so, if it seems like any of this is sort of really stalling us, I think then we as a group need to really think about this advisory thing.
Yeah.
And whether you want to just say thank you and move forward.
So we're agreeing then to table it.
So just, so what's on the table is tabling this for 1 month with the intention that it'll be resolved within 1 month. So if anybody is not in agreement with that, as Member Short is bringing up, or is concerned that it's gonna delay it longer, then this is the time to voice that.
I don't like doing it in a month, but I think we're probably in a position where we probably need to do so. But I would like to know that, because obviously the department has reviewed these. On the factual side, is there anything in the resolutions from a factual basis that the department thinks that we ought to know that maybe we assumed but may not be accurate?
Oh, I don't.
I just want to be here
Yeah.
next month.
Of course, no. I don't think there's any factual issue with
Okay.
resolutions, no.
Okay, anybody concerned enough about the delay that they would rather not delay and instead vote today on the resolutions as written?
Do we need a motion to do this? To do what we want to do?
I think we can do a motion. I don't think we have.
I don't think we.
I think the minutes need to reflect that that the consensus of the group is that we reconvene the working group, adding the chair.
Yep.
To meet with the city attorney's office to discuss resolutions.
And the working group right now is going to be Sarah, you, Steve, correct?
No, Ally's part of the working group.
Unless
And
we're
Vika-
at.
and Vika's part, I'm sorry, Vika's part of the working
Because I
group.
wondered if,
Is that right? It was the four of us, wasn't it?
It was, but there was also like at the end, both of you kind of
Yeah.
finished it. So I didn't know if
I
like,
let somebody out. I thought.
But for Sunshine, how many max?
I think six.
6 is max, so we're
Six.
still under 6.
So we're fine.
All right.
all right, so as chair,
Okay.
you can say we're going to.
Okay, so we'll table the resolutions, pending the input from the city attorneys, which will go directly to the working groups. And the date for that meeting is to be scheduled. And then we'll come back, at our next IWG meeting in May to either consider the resolutions or for the working groups to report back on, what changed or why we're not considering them. Does that sound okay?
All right.
All right, and now I see Director, public comment. Okay, so let's see, is there any, go ahead, Diana, sorry.
You know, I feel like my spiel. Members of the public who wish to provide public comment on this agenda item, which is discussion item 3, street crisis response team resolutions, are invited to participate in one of 3 ways. In person, then after the in-person people have had their chance, we'll call on the people who are on video. If you're participating by video, raise your hand and we will call on you when it's your turn to unmute you. We will then call on those joining by phone. If you have joined by phone and would like to provide public comment, please call 415-655-0001. Enter access code 2482-596-1324. Press pound and then pound again. Dial *3 to line up to speak. The system prompt will indicate you have raised your hand. Please wait until the system indicates that you have been unmuted and then you can begin your comment. All public commenters will have 3 minutes. I will give you a 30-second warning when your time is nearing completion. Would anybody in person like to do public comments? Is there anybody joining on phone or video who has their hand raised? Jump up and down if anybody sees a raised hand. Haley, are you seeing any hands raised?
I do not see any hands raised.
And I'm seeing there's a member of the public in the attendee list, just double checking. Please take a look at those instructions and raise your hand if you would like to speak.
Okay.
Public comment is now closed.
All right, and now we'll go back to discussion item number 2, the director's update by Dr. Larry Cunnins. Dr. Cunnins, I think, is on the line now. Welcome, Dr. Cunnins, and we're excited to hear what you have to share.
Hi all. Sorry for the my difficult schedule this morning. So thanks for everyone's forbearance. I came in on the end and was listening to the next steps with the resolution, and I will be sure to catch up with my team and with Member Hammer as well, who I understand is chairing the meeting today. So it's funny, I can't really see everyone so well in the room, but welcome to 1380 Howard, everyone. It's really nice to be able to host meetings and feel that our space is your space and sort of part of all the work that we're doing. And so apologies, I'm not there with you. I have a couple of talking points and updates that I wanted to share with you. I suspect some of them have come out already, and so please forgive me if I'm repeating. We, first of all, had an important milestone earlier this month in announcing the opening of 70 new residential step-down beds, which are located on Treasure Island. This level of service is something we call step down, as we've discussed here internally in San Francisco, which is a service that is transitional housing and support following somebody's completion of a residential treatment program for up to 24 months. And it allows a person ongoing support with their recovery, as well as support while they continue to participate in outpatient level of care treatment and seek employment. The nomenclature is San Francisco specific. I just want you all to know in the state sort of nomenclature in levels of care, it's often called recovery housing. And so I just want folks to be aware of that. It's now accepting clients. We are partnering, as Dr. Pading may have relayed, with Health Right 360 to operate the program, including these new 70 beds. We now are operating a total of 232 residential step-down beds. This is really an important expansion in our ability to meet the health needs of clients at all stages in their care and recovery. I also, just on the programmatic update side, we just wanted to make all of you aware, we mentioned at an earlier meeting that our RFP to expand intensive case management services is issued, and that RFP closes to applications May 2nd. Switching a little bit of gears, is in the kind of wanting to keep everyone briefed on sort of the multiple oversight and auditing and other compliance work that is pretty consistent with our services and sort of what we are doing, and what, thanks to our wonderful Quality Management and Mental Health Services Act staff, we have recently completed in December our annual California External Quality Review, which is called EQRO for short. That is an annual review often broken into two parts, one focused on mental health, one on substance use. We also just recently completed our Mental Health Services Act programmatic review. I think, as you all know, the Mental Health Services Act, or MHSA for short, is a state funding stream to fund services in a fairly, to some extent, in a prescribed way or prescribed buckets. That audit, there is a triennial audit, and that we completed in March, and we'll hear back soon about our results. And then finally, just last week, we completed the Department of Healthcare Services Mental Health Plan triennial audit. That is a very large audit, and all of these audits really enlist many behavioral health administrative and clinical staff. The results from our mental health plan triennial audit will be sent to us within 3 months, and then we will get busy responding, hopefully to less rather than more findings. And then last but not least, I wanted to share with you some updates from the Board of Supervisors. As we mentioned, I think I mentioned last meeting, there is going to be a new committee that will begin meeting called the Homelessness and Behavioral Health Select Committee. The first meeting of that committee will be this Friday, April 28th. This committee will be meeting the second and fourth Fridays of each month at 10 a.m. with Supervisor Ronan chairing the committee and with participation from other committee, Board of Supervisor committee members, Supervisor Mandelman and Supervisor Walton. Of note, we will have several contract presentations over the next 6 weeks. This is where, as has been true all along in the Finance and Budget Committee, the contract presentations will now move into this committee. Additionally, there'll be a hearing on the implementation of Care Court during this committee on Friday. And of course, any and all of you are most welcome to listen in and, of course, provide public comment as well. So that is a concise update. Let me continue on. We have 2 more. I know that you guys have been talking about SCRT this morning. Let me just add a bit of an update about what we are now calling best neighborhoods. And I can't recall whether we used that nomenclature at our last meeting, but we, as you know, we're transitioning our role within Street Crisis Response Team, really aiming to enhance our, as you also know, what we are describing as our proactive neighborhood-based street care model. We have named it as Best Neighborhoods because it is part of the Office of Coordinated Care. And as of March 26th, we are aiming to serve high priority neighborhoods, aiming for 7-day-a-week service. In addition to the high priority neighborhoods, which have dedicated teams, although can flex to different neighborhoods as needed, an additional team will be covering clients outside of the areas. We will certainly adjust as we go and aim to really meet people's needs expeditiously. I think also, as you know, our goal is to enhance the intermediate and longer term follow-up support for individuals who are interacting with the street crisis response teams and who need ongoing behavioral health care. I think I'll stop there. I'm guessing, and I'm happy to take questions and to continue the conversation. Thanks so much.
What are the priority neighborhoods that have been identified for the best?
Yeah, let me read.
Neighborhoods.
Yeah. So the priority neighborhoods include, for the moment, Tenderloin and Soma, Mission and Castro and Fillmore. As we increase staffing, we had a big, which we are doing in the transition, there has been a decrease, hopefully temporary, in staffing we will adjust as we go and as we need to. And so I'd like to invite everyone to sort of not think of these as fixed. I think what I would like to invite everyone to do is think about how we are overall prioritizing by number of SCRT calls, number of requests for service in ways as we collaborate with our community members, with businesses, with other community organizations where there is we are receiving requests for assistance in any given neighborhood. I think anyway, I'll pause there. I don't know if that, I think that was Member Salinas who asked that. Does that, it has that?
Yes, thank you.
Dr. Kunis, can you say a little bit more? You mentioned something about aiming to have long-term care, focusing on transitioning to some longer-term care, you say? What?
Oh, yes. So the focus is getting people navigated into sort of the definitive service for what they need. Meaning the idea isn't we're case managing and working and care coordinating indefinitely. We want to complete the assessment of their needs, whether it's and getting folks placed, whether it's ICM, intensive case management, whether it's outpatient care, whether it's potentially the need for involuntary care in a residential setting or voluntary care in a residential setting. So in other words, the idea is that we are not wanting to duplicate the existing system or systems of care, both those have been expanded under MHSF and otherwise. Does that make sense?
Yes, that's great.
It's Sarah. Hi. I tried to ask David Pating this, put him on the spot a little bit. Considering the hearing is on Friday for care courts, what I asked was just sort of what kind of pressure is this expected to put on the beds and facilities, you know, you've already been trying to provide and your whole plan for that. But I kind of have an additional question for you, which is, you know, I know there was an article, there's been at least the more recent one, an article in the Standard talking about the cost of implementation, particularly actually providing things like housing and services to folks, to the patients, and that we're nowhere near that. And so that's really concerning, but not surprising. And so I also wonder, I guess, does DPH, I don't even know if you're allowed to, but like sort of have a position on the implementation of care courts that you'll be, you know, presenting at the hearing, or maybe it's better to frame it as a request or ask for support around how to make it work. I know I'm asking for a sneak preview because we'll see this Friday, but anything you can tell me about all of that.
Thanks for the question, Member Short. So, yeah, Dr. Pating has not been so directly involved with care court planning and implementation, although to some extent we're all there. And you'll hear more at the hearing. I think our position is that it is, so first of all, it's a requirement of that we do this at the county level by the state. It is a program that we are happy to be participating in and are thinking about it as another tool to expand our ability and potentially resources to help get people into needed care. We know that, and the state has provided startup funding as well as what we anticipate to be some ongoing funding. We're not sure what that will be. Additionally, the state has provided something called a bridge housing grant. Again, it's not ongoing money, it's one-time money with careful descriptions of what kind of housing and supports could be used. There are some constraints on that money in terms of how that it must be used very quickly and it must be used for some things and not others. So we are applying for that funding. I think I had mentioned previously that it is an allocation to the county this round. Subsequent rounds, I believe there will be 2, will be competitive, and we intend to apply for them. I should also add, we are very closely collaborating with HSH on this application. So we are really aiming to work together as sort of the city in figuring out what is eligible and what we can get off the ground quickly and what will meet the needs of Care Court and other San Franciscans. I think underneath another part of your question, Member Short, is really important, which is how and whether this will put this Care Court implementation will put pressure on other parts of our system or systems. I think I'll answer with the sort of I don't know part first, which is because it's a new program, to some extent we are doing our best estimates and we know that we will have to adjust as we go.
That's what David said.
Yeah, so, oh, good. We're all
on the same page.
We're all the same. Another part is we expect there to be overlap between who we already know about and needs care and who we don't know about. So a lot of the, we think, a lot of the Care Court population is already, in some sense, the population we've designed as priority populations for mental health SF. So that is part of what we are anticipating. The other part of what we're anticipating, and I feel like we'll have to, keep ourselves and you appraised, is we expect there to be a need for ICM level of care. Now, if to the extent that this may represent new folks coming in, we already know there are pressures on ICM, and that is a concern of ours. We think that the residential part will be less pressureful, if that makes sense, because we expect there to be fewer of that level of need. But again, we're watching closely. The folks internally who are leading this are people you already know, Dr. Gonzalez, who is amongst you, Dr. Almeida, or have been doing a lot of the program planning and thinking through, and we do with our startup funds intend to hire dedicated staff, which will be needed both for program management, for the assessment and mechanisms, and clinical recommendation mechanisms, as well as for tracking and follow-up, and that is underway.
Thanks so much. I'll see you Friday there, or I don't know if you'll be in person.
I have a question and a comment going back to the best street or best neighborhoods team. I forgot to ask that. So how will folks be identified? Are they coming in through 911 calls or through Mandelman Specialist or both? And two, just my concern, just piggybacking on Sarah's, that our ICM, everyone's getting referred to ICM, and our ICM case managers, we're constantly working with ever-changing systems that don't exactly support the case management goals. Folks, getting housing is always the primary thing, right? Folks aren't going to be able to really effectively engage in treatment if they're not housed. So, years ago, we were getting people on wait lists, and then all of a sudden navigation centers open. And then anyone who went to the navigation center suddenly got bumped to the top of the housing list. Meanwhile, we have folks that have been waiting 1 and 2 years to get housed. And so, of course, the savvy case manager does start, trying to hustle and get their client into navigation center. But it's, so then we have to, we've been doing something one way, then it switches up on us. And then our clients are bumped up. are bumped down. You know, when the SIP sites opened, we'd had all these people that were prioritized that we went through, you know, getting them, you know, that through this 1 hour assessment, having to do, you know, that 11-page DAW clinical review form, you know, all this, and they're waiting for a year, and then all of a sudden they're all bumped, and then they're waiting another year to get housed. You know, now you're going to implement care courts, you know, and then there again, you know, folks that have been waiting are going to get bumped. So the savvier case manager is going to try and see how they can get their client, you know, into care court, because that's going to be the new way while everyone gets bumped who's been waiting. You know, when the emergency, what was the site called? I'm forgetting right now. In the TL, we were hearing, oh, some of those folks, if they go there, if you're one of these first, whatever, 5 people that get there, maybe you can get them prioritized for housing. So you've been waiting for housing. So then, you know, it's like there's constantly like we're doing something and then the thing changes, who gets prioritized. So then it's like we're constantly chasing our tail. And so I think that just to point that out, you know, so this is going to roll out, and particularly, you know, for the crisis response team that we have, and the linkage team and the AOT team, you know, and us that get them referred for long-term, you know, it's like we're going to have to, like, you know, the relentless relentless advocates are going to then, you have to constantly be working the system. And I hope that there is a way that we can roll out things, but have some consistency, and that what people have been working for a long time don't suddenly just get bumped.
Well, I'm not sure thank you, I think, for raising, Member Salinas, the importance of housing to stability. So just to I want to really acknowledge that. I think this is important feedback, and I think, you know, bringing this back to all of our sort of colleagues in HSH, Dr. Gonzalez is hearing this in the room, I think, or she may be online, I don't know.
She's here. That's her waving.
That's her waving. You guys are like little tiny dots.
Yeah.
And like, and the other thing I will just sort of remind you and all of us is the care court has very narrow and specific eligibility. So this is not going to be a go here, you'll be prioritized. Just to be clear, this is submitting a petition, getting the petition evaluated by the judicial system, having the clinicians evaluate the petition for eligibility. So there's multiple steps here. And then plus, and Annie, please correct me if I'm not getting the language right. This is for people with psychotic spectrum disorder. I believe I'm using exact language from the legislation, and who cannot survive safely, or unlikely to survive safely in the community. They may not meet criteria for grave disability, and need to voluntarily accept, you know, ultimately there's no stick here, just as far as I understand. So there's no court order for treatment in the same level of threshold as for AOT, for example, or for a conservator's office. I think there's some questions about how this is, you know, going to get worked out, that we are know that will, you know, as any program in the implementation detail, you know, as we implement, more questions, more operational and policy questions will arise. But I share our and your desire that we want to steadily work on the people that we will continue to prioritize by all the ways that you just described. I think, Annie, anything else to add there?
Can I add stuff? I think the other important piece is that for eligibility is that for someone to be eligible, they are not voluntarily engaged in care. And that's a really important distinction, because I think, you know, a lot of the people that we treat or, mostly voluntary engaged in care will not be eligible for care courses. Something to sort of keep in mind.
Thank you.
But I would say that description of not voluntarily engaged in treatment is the bulk of is all of AOT, is all of CCRT, and to some degree, the linkage folks. So our whole stabilization program that serves at how many, maybe 200 folks. I mean,
But
they're definitely not voluntarily engaging in care.
The AOT, there's like a broader criteria, and this is very narrow. Schizophrenia spectrum and psychotic spectrum disorders, and it's very clear about that. And so it's much narrower than AOT.
And do they have to be previously diagnosed, or could someone say, oh, they might be eligible, let's, check them out, and we now have a diagnosis of, and so.
Yeah, I mean, ideally, yes, because you're supposed to submit a petition that's supposed to have information of extent diagnosis. You have to sort of give, supporting documentation. That's all part of the petition.
Yeah,
So,
that makes, okay, yeah. Again, we'll learn more Friday, right? Hopefully.
Okay. Thank you for your report, Director Cunnins. Any other questions or discussion? If not, we will go to public comment.
And if I may, I think so. My day got a little bit unraveled today. I apologize. I need to jump in 2 minutes to another meeting. So I'll be here for another 2 minutes. And of course, we'll see you all next month, if not sooner.
Right, okay. So members of the public who wish to provide public comment on this agenda item, which is discussion item 2, the MHSF director's update, are invited to participate in 3 ways. One is in person. The other one is if you're online. If you're online and would like to make a public comment, please raise your hand and we will unmute you when it is your turn to speak. If you are calling in and would like to make a public comment, please dial 415-655-0001. Enter access code 2482-596-1324. Press pound and then pound again. Dial *3 to line up to speak. A system prompt will indicate that you have raised your hand. Please wait until the system indicates that you have been unmuted, and then you may begin your comment. Note that all public comment is limited to 3 minutes. I will give you a 30-second warning when your time is nearing completion. Is there anybody in person who would like to do a public comment? Okay.
Please,
Yes.
please step up.
Yeah, so there's one here and there's one there. I will start your time when you start speaking.
Hi, I just wanted to say, I got here late and I don't have any of the literature in the past. Usually there were copies for the public that showed up at meetings this type. I don't know if they're not doing that anymore. I haven't heard anything about elders, housing for long-term psych elders, like nursing home sorts of places. Many elders have that have been taking psych meds for a really long time, developed dementia, and it seems that San Francisco, since they closed the old Laguna Honda, doesn't really have anything like that. I'm just wondering if anybody's thinking about that particular population. Thank you.
Thank you for your comment. And just a reminder that in general, we don't respond to questions, but we'll make sure that the new beds and facilities team heard your question and noted it. I mean, yeah, question, your comment. Thank you. And do we have?
I have another one. Yes.
Oh, sorry.
I'd just like to say that I think something that would be essential is an evaluation of AOT, SB 1045, community conservatorships, and all of the existing mechanisms we have for involuntary treatment and implementation development of care court, because there's obvious problems, especially with a population that's now a narrower target population that has less specificity, or more specificity in its eligibility criteria. For AOT, it's incredibly underutilized. And we all know SB 1045 was incredibly underutilized, and we know community conservatorships are incredibly underutilized. So that seems to be something that would be essential for creating a meaningful new program.
Thank you for your comment.
Other in-person public comments? Anybody online who wishes to make a public comment, please raise your hand. Like your virtual hand, not your like actual. I mean, I guess you could raise your actual hand. I don't see any hands raised. Does anybody see any hands raised? Haley, do you see any hands raised? Nope. Okay. I believe we can close public comment. Okay, public comment is closed. And then we're gonna go to
Do a final comment.
Okay, but then it seemed like there's a bunch of stuff in here that we didn't get.
That's after.
That's after. Okay, final public comment?
Okay.
Do we need to read it again?
We always
I asked.
Read again.
Okay, I will read again.
We'll check into that, whether we need to keep on reading.
Yeah, that's a valid question. So this is the final public comment. So, oops. Members of the public who wish to provide public comment on any other matters within the jurisdiction of this committee that are not on the agenda, you could do so in one of three ways. One is in person. One is if you've joined online, you can raise your virtual hand and we will call on you when it is your turn to speak. The other is through phone. If you'd like to comment via phone, please dial 415-655-0001. Enter access code 2482-596-1324. Press pound and then pound again. Dial *3 to line up to speak. The prompt will indicate that you have raised your hand. And please wait till the system has indicated that you have been unmuted. Then you may begin your public comment. All public comments are limited to 3 minutes, and I will give you a 30-second warning signal when your time is near completion. Is there anybody in person who would like to make a public comment on any other matter within the jurisdiction of this committee that was not on the agenda? No in-person folks. Anybody online with their hand raised? I do not see any. Does anybody see any raised online hands?
We have secondary validation that there is nobody else.
Did you see any hands raised?
No hands.
Okay. And I think I recommend we close public comment.
Public comments closed. And now we're going to planning for subsequent meetings.
Yeah, so just a couple of slides to run through. That's on hold because we're working right now on, go back, please. We're on hold for the planning and sequencing because we're working internally with DPH to set up the timelines so that those happen. So this will be coming and this will be part of our now future planning process that we're working towards. So just wanted to note that. Next slide.
Before you leave that slide, do you know if there's any, it's been a long time since we've had a report on the Mental Health Service Center development. Is that something that is going to be presented in the near future?
Oh, well, yes.
I can give David and I discussed, there it goes in his update, they're conducting a site search. He has been doing for many of these other things, real estate search process. So that's the reason for substantive updates. It's real estate.
On the radar screen, but there's no blip.
Yeah, I mean, real estate process is more like there's many blips, and then we investigate them, and they get taken off because they can't be used.
I won't get into
So
describing what the blip is.
it's a great deal of the work of what New Beds and Facilities does is behind the scenes is reviewing many state continuously going through the process with our real estate division, investigating whether it meets our requirements, investigating what requirements are needed for different levels of care, and then
I'm only raising it because while it's got tremendous developmental construction and staffing and other issues to come to fruition, it was the centerpiece
Agreed.
of mental health FF. And it seems like it sort of disappeared for a while.
I would,
So let's not get too far into mental health services center. I think it'd be great to get an update. I do want to also just point out that looking at the legislation, I mean, the way that that's sort of evolved is the Office of Coordinated Care, which is not a brick and mortar site, but is is fulfilling a lot of the functions. I think has sort of become more of the centerpiece, and I think it would be great for us to have a formal report on that. I do want to move us along, not get too much into mental health services center. Regarding this slide, so it looked like the intention was to have reports from OCC, A&E, and the staffing study for this month, but that didn't happen.
Yes.
So is everything in flux, or are we pushing those three things forward to May?
Yeah, some of those are moving forward. Okay, so if there's a couple slides on that.
Okay,
next.
okay.
So can we go to the next one? Okay, the next couple slides, all right. Yeah, there's a couple. So first, we'll go one more slide. Haley. Related to that.
Okay.
So our next meeting is going to be in May. There are two suggested topics that DPH has suggested we dig into. One is the controller's office is coming back with their staffing and wage analysis.
Great.
So that, huh?
I got something today.
Oh.
Great. So that'll be,
So that's coming up, and in just the next thing that we'll talk about is like some input they would like from you before the meeting in keeping with
Okay.
kind of our ideas. Prop C budget is another thing that they talked about coming. So we talked about that. Andrea's like bringing that more into the fore. And then there are some other options, is like the analytics and evaluation team has been doing a lot of work, and that has to do with some of the things we talked about today. And there are a couple of other things we could talk about, including the housing and homeless support, like the nexus that they have with you, as well as the overdose prevention dashboard. So
we
wondering,
also have the resolutions.
the resolution,
The topic on the agenda.
resolutions have now moved over. Yep.
So is the thought that we would agree on one of those other options to add to the other three? Or is that a full enough agenda for
It's
trying
gonna
to
be
get
pretty
to
We'd have a
three?
9-hour meeting.
Yeah.
So I mean, we have three agenda items, so anybody have a strong feeling that one of those other options we need to move up to May, or should we pencil those in as June topics?
Okay, with June.
I have a comment not related to that, but since we are definitely talking about the staffing and wage analysis, can the city attorney preemptively send something? I mean, because you've got, the CBO, you've got myself, Vika, Steve Fields. I mean, I think, can they just, rather than us having to individually reach out to, can he just prepare us for that meeting and help us to understand how to navigate? Thank you. That
Idea. Okay.
So then, so the next meeting.
Wait a minute.
Oh,
Well, I have one other agenda topic, probably for the next meeting, is it seems that we should have a report at each meeting about the Board of Supervisors Subcommittee meetings. I mean, not all of us will be attending them,
Yeah.
listening to them, but we should get reports as to what was discussed or what action was taken.
We could also ask Director Cunnins if she can work that into her reports. And
I'm
bring it all up.
happy to go either way, but it seems that we ought to
That
have,
makes sense.
but we ought to have some type of report.
and I
It's
would
not always
imagine,
going to even cover any behavioral health stuff.
yeah.
So you just never know. Yeah.
So, yeah, so maybe we could talk to them.
Let's talk to her about it. Yeah.
Can I request, I think I've asked this before, and I think I got just kind of a drop of a number. I did ask before to give us a data of the, since we're talking about staffing and wage analysis, and I keep hearing all these staffing issues, hiring issue, retention. Can we get some data as how many CBOs are hired, or how many city employees hired? I think I've asked that before. And I got a number of like several hundred city employees were hired. But I keep hearing, well, there's these problems of retention, people leaving issue. So I just like to know where that number is according to the budget, and what is the problem that we are having trouble? Not only retaining, but then also recruiting.
So there's a whole team, I think, in behavioral health services, which is focused on the workforce, so hiring, developing the workforce and stuff. Are you thinking just ask Dr. Cunnins to like give us some numbers
Well, I
in
just
her
want to
report, or should we ask for a formal report?
Well,
from
I
the-
just want to make sure, because then before this whole planning committee started, that we were, assured that we're not going to have overflow of the CDO staffing versus the city employees,
Okay.
because that's what my concern is.
We will get this sufficiently ahead of, I mean.
Yeah. Yeah.
Please.
I mean, we just got it, I think.
Oh, yeah?
Is that?
Is that it? I don't know.
Mike,
We
I
just
got it and what?
Staffing and wage analysis, though, is not going to include what number one is requesting, which is a report on our hiring related to mental health asset
Yes,
implementation.
thank you.
Valerie, is that something we can ask for as just a, maybe not a formal report, but just give us like a written, some numbers from the team? Yeah. Okay. That's done, okay? Great. Okay. Great suggestion.
Okay, so what we will focus on next time is the staff and wage analysis, the Prop C budget, the resolutions. We will be working on getting that information to you early so that you have a chance to look at it. And analytics and evaluation, and perhaps the other ones will be pushed back to June or a later date, depending on what the other timelines are coming together. There are 2 opportunities between meetings to be involved. Can you go back up a slide, Kaylee? One of them is related to the staffing and wages discussion group. So this is that, they are looking for a group of people who can provide feedback on the controller's office interpretation of what's coming up.
And I have to remember is there a recusal, or can people whose organizations are going to be impacted part of that discussion group?
Oksana and Mike, you're on the phone. I'm wondering if you can unmute yourself and if you have an idea about that. Or if that's something we need to check on.
I'm sure we can circle back. We don't have too much additional context based or on the staffing and wage analysis more than what's already been listed. But if there are specific questions, happy to kind of loop in the team or kind of help coordinate that discussion group.
Okay, you could just let us know whether IWG members who are part of organizations which will be impacted by the report, whether they can be part of the feedback group.
Okay, yeah, we can circle back with a city attorney and ask about that. There's a conflict of interest.
Yeah, I imagine you can, because it's just a discussion group.
Well, and I think about our recommendation though map that we had, is that there's a yellow spot there where you start getting into, you have to be really careful. So I think it's the yellow spot that's helpful to check in on.
There's
And
not a conflict of interest.
Yes,
but-
Steve?
Yeah.
The reality is that most of us were involved as in the cohort study that produced it. So the nonprofits were the focus of a lot of it. So we've already been involved. So
You have, I think the issue will be the interpretation.
Yeah,
Going to be
the feedback on the
Yeah, so
interpretation.
involvement is one thing, interpretation is probably a different level of.
I would say it's the level of recommendation. We just had a meeting with the controller, 2 of them last week, on the interpretation. It's not just data. They've been meeting with the nonprofit sector regularly to give us, as this process has gone along, what they're finding. So I think the conflict of interest for the IWG is whether or not they're bringing recommendations to our body based on that report, and whether any one of us can vote on the recommendations as members of the IWG.
I see. Thank
They've
you for
already
that.
heard a lot of feedback from us on
Yeah.
this interpretation.
That's very helpful. Thank you, Steve. Oksana, you and I can touch base offline about how to get that answered.
That sounds good.
Thank you. Yeah, so there's a couple of dates that they're hoping for. So in our post communication to you all, that will be one of the invitations, is we'll try to get that out very soon after this meeting and get it ironed out about, because it will be, so there's some dates that'll be in those 2 windows of time to be able to meet. And I believe that there's going to be a couple of other opportunities after that. So if you apply for it, if you participate now, there will probably be a couple of follow-ons. Haley, please advance 2 slides. The other opportunity is we've been talking about over time, there's been some interest in talking to providers and making sure that you have that direct input. So there is a opportunity to do a Soma Rise site visit. And so what we've set it up to be is a 1 hour, it'll be up to 1 hour, sometime between 10 and 1 for the providers who were there. That's the time to do it. We'll send out a poll. We've already established a couple of possible dates, which is the 15th, 16th, or 18th during that time. In keeping with how we're organized, up to 6 members can attend. And it really be it seems like it will be a good opportunity because you will be meeting with a mental health provider, you'll be meeting, or a mental health worker, you'll be meeting an EMT, you'll be meeting a number of people and being able to talk directly to them and ask questions, as well as just to have a general site so you can see the pictures, like walk through it, ask questions. And just a note that this is also serving an evaluative purpose. So the IWG is one of the key stakeholders that informs Soma Rise. And so while you're learning, there will be an observer there who will also be asking questions and will be gathering your feedback as you go through the site visit itself. So it's kind of like an interactive focus group.
That's some good snacks there then, Vitka.
I think the cucumbers and fruit.
Noodle, yeah.
Oops. Yeah, so that opportunity, so you'll have 2 things to participate in if you so choose. One is a staffing and wage. The other one is this site visit to Soma Rise. And if you end up liking the Soma Rise and you want to do other site visits, we could talk about that if you would like to set those up. Okay, next. Usual housekeeping. Looking for a vice chair. Anybody's interested, let me know. Meeting procedures we posted always to the website. The website has lots of resources there. Encourage you to poke around in that if you haven't. And there's always an email address for public input that is open. And the final slide, I think it's the final slide. We just wanted to, this relates a little bit, Steve, to what you were mentioning is, there's so many bodies that are connected to this. You don't have to attend them all. And they do meet on a regular basis and they are posting notes and minutes like we are. And so there's an opportunity, like if you ever want to just track what's happening and how it connects, these are the groups that are doing all of the different interconnected things. So we're trying to get kind of a better feel and a better way to communicate, like when we're deciding on something, who else has their fingers in kind of deciding so that we can communicate that clearly. And I believe.
All right, so thank you everyone for a great meeting. Thanks to Jennifer. Did you bring the breakfast? Thank you.
Oh, no, Valerie, that's Valerie.
Thank you. Thank you for the breakfast.
Sharing.
Oh, thanks for sharing. Sure. I do want to just get a temperature check from people. Do people like this room and location? Because I think that we have another office in the Mission that has probably a better room, but if people like this location, which is moving into the behavioral health staff.
It sure does, huh? For those of us that live in the Mission dwellers are like, but it should be convenient for everyone.
Okay, so we'll check with Valerie's team to see whether we want to stay here because for the behavioral health staff coming in now, it's convenient, but otherwise we may move over to 14th Mission. Or 14th in Valencia, sorry. Better to a bigger room. And okay.
Parking there?
Nope.
Really good coffee though.
Close to park, very close, right there. Very good. Okay, so can I have a motion to adjourn the meeting?
Move to adjourn.
So Steve Lipton.
Second.
Second.
All right.
Vitka. Just calling out for our minute.
Got it.
All right. The meeting's adjourned. Thank you, everybody.
Thank you. To say, I almost brought like a puffer jacket or something like after reading the email. It was like, beware, the room could be really cold. In here, I'm like, what temperature in this building is?
I have a poncho and a scarf.
Funny, I really was like worried about it.
Little binder.
Oh my God.